meeting is now live on the internet.
Good afternoon, Doug. Would you like to do a quick mic check?
Yes, can you hear me well?
Loud and clear. Thank you.
Thank you.
Good afternoon, Dr. Day. I see you've joined us. Can we do a quick mic check?
Sure, mic check. Can you hear me?
I can. Thank you.
Yeah.
And good afternoon, Jackie. Would you like to do a mic check?
Good afternoon. This is Jackie.
Thank you. And Renee, would you like to do a quick mic check?
Hi, good afternoon.
Thank you. And good afternoon, Jeff. Would you like to do a quick mic check?
Quick mic check.
Thank you.
Thank you.
Good afternoon, Heather. Would you like to do a quick mic check?
I should probably unmute myself, huh?
It helps sometimes. Thank you.
You're welcome.
And good afternoon, Dawn. Would you like to do a quick mic check?
Good afternoon.
Thank you. Good afternoon, Meenesh. Would you like to do a mic check?
Sure. Good afternoon. This is Manesh.
Thank you. Good afternoon, Julie. Would you like to do a mic check?
Hello.
Thank
Happy to be
you.
here.
And good afternoon, Tyler. It looks like you were having a little trouble logging in. Can we do a mic check? And Rhonda, can we do a quick mic check?
Hello, I'm here.
Thank you.
Thank you.
We have a participant on the panel with a phone number ending in 260. Can you identify yourself so we can rename you, please?
Hi, this is Laura Rosas, CEO of VHP.
I'm sorry, I'm having a little bit of trouble hearing you. Can you speak up, please?
One moment. Is this better?
A little bit. Can you give me your name one more time, please? I'm sorry.
Laura Rosas, CEO.
Oh,
of
okay.
VHP.
Hi, Laura. One moment.
Sorry about that.
Good afternoon, Key. Would you like to do a quick mic check?
Hi, this is Keith. Thank you.
Thank you. And Doug Koenig, can we do a quick mic check?
Okay.
You are loud and clear. I heard
Okay.
that.
Okay. Thank you, Peg.
Thank you.
Hello, Supervisor Smidian. Can we do a mic check so we can hear you? Make sure that you're connected.
Let me ask the clerk of the board if they can hear me. This is County Supervisor Joe Simidian with a little tech problem here.
We can hear you. Thank you, sir. We're still waiting on Supervisor Lee. We have not seen him just yet.
And again, we'll ask the clerk of the board if the clerk can hear me. This is County Supervisor.
We can hear you, Supervisor. Can you hear me? Oh, dear. Can you hear me?
Well, let me ask Dr. Jeff Smith if he can hear me.
No, yes, I can hear you.
Shaking his head. All right.
I can hear you.
We can hear you, but you can't hear us. Can you hear us now?
Dr. Smith, it looks like he signed off and might be trying to sign on again.
While he is doing that, Mr. Smith, would you like to do a quick mic check?
I'm here. Can you hear me?
I can, thank you.
Hello, everyone. This is a courtesy announcement. We are waiting for the supervisors to arrive. It looks like they're having some technical issues. So as soon as they show up, we will start the meeting.
Good afternoon, Supervisor Semidian. I see you're back. Would you like to do a quick mic check?
Yes, this is Supervisor Joe Simidian. I can hear you loud and clear. Can you hear me loud and clear?
We can. Dave Leon will be clerking this afternoon, and we are waiting for Supervisor Lee.
All right, then. And my apologies to all who have been sitting patiently through our tech challenges these last 5 minutes.
Supervisor Smidian, this is Dave. Can you hear me?
I can, Dave, and can you
Okay.
hear me loud and clear?
I can, yes, thank you. Just wanted to make sure we had a good connection. I am currently checking on Supervisor Lee, and I will update you as soon as I hear anything.
Thank you so much. Let me turn to the clerk and ask if we have any word.
I am currently checking with his staff. They are checking and will let me know, and hopefully I should have something for you within the next couple of minutes.
All right, Ms. Leon, why don't we do this? Just mindful of the fact that we may have folks who would like to make public comment at this time. I'm going to call the meeting to order at, for your record, 1:38. Thank everyone for their patience and ask, I will note for the record the absence of a quorum because we need a second member. But I will go to item number 2 as a committee of the whole for public comment and ask if we have anyone who has indicated a desire to speak under public comment, which is, of course, that portion of our agenda set aside for comment by members of the public on non-agendized items properly within the jurisdiction of our committee. Do we have any speakers who've expressed an interest in public comment?
We currently have one speaker, Mr. Chair.
All right. Well, if he or she would like to go right ahead, why don't we accommodate them so that we don't keep them waiting any longer. Go right ahead.
Okay. Our next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You will have 3 minutes to speak. The timer will start when you begin speaking.
Good afternoon, everyone. Scott Largent. I'm sitting here with a friend of mine, and we were, he just brought up that it would be great if these meetings actually had feedback, if there was communication back and forth. I understand county council always, raises that red flag and, oh, don't talk to the public, don't let him speak anymore, hit the button, hit the nuke button, stop him. It would just be great because people come in there and they're looking towards you supervisors and you commissioners. You're supposed to be healing administrators. You're supposed to be the right people to talk to. You're the shot callers in our county. And I just worry you guys just tune it out. When I used to go in there in person, you guys would have your cell phones glued to your foreheads. You wouldn't even pay attention when I'd walk up there to public comment. You do this for the elderly, the disabled. It was just shocking. You know, you guys kind of got the point for a little bit and started actually looking people in the eyes, but it was just, maybe we could do that this next coming year as things start to reopen and our county kind of gets back in order. What I would like to talk about today, do you guys ever go on field trips? Do you guys want to come out to where I live in the crash zone out near the airport? I think you guys should come over and have coffee sometimes. We'll socially distance. I've had my vaccine, and you can truly see the suffering that goes on right before you land at the San Jose airport. I really would like you guys to come out. And I think the only person that would really have the courage to do that would be Otto Lee. He does go to encampments. He gets out there in the creeks. He talks to people. He tries to help them. The rest of you guys kind of run the other direction. Joe, I think it would be a good idea also, Joe, for you to come and talk to your constituents that got swept from Palo Alto near Stanford University. Great group of people. I've been talking to them a lot. They need some help from you. They're voters, they're taxpayers, and they got swept away right into San Jose like we all end up over here. Also today, the San Jose Police Department decided to have track day on the Guadalupe. They were going up and down on their motorcycles, and you know, it looked like there was like a funeral procession or something. I was pretty shocked. That's harassment, that's intimidation, and it's really mean to do to the mentally ill and homeless that have been basically left out in the elements for the last year. And guess what? You guys don't give a crap about what I have to say. So let's just be honest, okay? Where do we take these people? How do we help them? And why are all the advocates ending up being the counselors, the social workers? You know, why are the people in retirement doing your guys' job? So I am, what did my dad used to say? Shit or get off the pot, right? That's a good one. Thank you.
That concludes our speakers.
Thank you very much. And then we
And
will.
Mr. Chair, I
move
apologize for
on
the
to
interruption,
our-
sir, but it looks like Supervisor Lee has arrived.
Great. Then we will say welcome to Supervisor Lee, and we will ask the clerk to call the roll to establish the presence of a quorum, which was item number 1.
Vice Chairperson Lee
Present.
and Chairperson Simidian.
Present.
Thank you.
And Supervisor Lee, I'll indicate we had one speaker under public comment that I think you arrived for just the tail end of that comment. That takes us now to item number 3, which is the approval of our consent calendar and our published board agenda. And if that meets with your approval, I would entertain a motion to approve the consent calendar items and the agenda as published, sir.
Sure do, and so moved.
All right, motion by Supervisor Otto Lee, second by Supervisor Simidian. Let me just confirm with the clerk that we do not have speakers on the consent calendar.
We have no speakers on this item, sir.
All right, then without objection and hearing none, that item is unanimously approved. That takes us to item number 4, which is the recommendations relating to medical staff and various allied health professionals at our health and hospital system. And we have possible actions A, B, C, and D. I do believe we have a presentation, and there's Dr. Kranis. Go right ahead, Doc.
Thank you so much, Supervisor Simidian and Supervisor Lee. Good afternoon. I'm Yvonne Kranis. I'm the Enterprise President of the Medical Staff, and I'm here to present for approval the Enterprise Credentials Report, the Enterprise Pediatric Nurse Practitioner Privileges, and the O'Connor Hospital Robotic Thoracic Surgery Privileges. Happy to answer any questions.
All right. I have no questions. And Supervisor Lee, any questions before we turn to see if there are members of the public who would like to speak?
Yes, please. Thank you, Chair Simidian. Yes, Ms. Karanis. I had some inquiry actually from some of our employees relating to the pediatric nurse practitioner of that privilege and that change. And there were some concerns that this change would negatively affect their ability to help with apparently it's a pretty rare skill set that's been used for a long time. So would you elaborate that a little bit for us, please?
Sure, thank you for your question. I'd like to start by saying that the medical staff's primary focus is to ensure the safety of our patients and providing the highest quality of care. And for patients to allow us to perform procedures on them or their family, to cut them open for surgery, is really a profound demonstration of their trust in us and our system. And the medical staff honors this trust by ensuring that all of our providers have the education, training, skills, and current competency to perform the privileges that we grant them. The medical staff has been working to create enterprise-wide privilege sets so that we have a uniform standard across the system and to be in compliance with Joint Commission requirements. Across the system, many of our current privilege sets have not been fully reviewed in several years and have required updating to current practice. This current document, our enterprise privileges for nurse practitioners in pediatrics, went through a lengthy medical staff review process. It was reviewed by the individual departments at all 3 hospital sites, where input was sought by the current nurse practitioners and other stakeholders. It was then reviewed at the Enterprise Interdisciplinary Practice Committee, the medical leadership councils of all 3 hospitals, and the Enterprise Medical Executive Committee. And so again, this has just been a lengthy review process. And these privileges impact the NPs, the nurse practitioners, and all pediatric specialties at all 3 hospitals, not just the neonatal ICU nurse practitioners. So this question has come up now regarding the removal of the pericardiocentesis procedure from the core privileges for the neonatal ICU nurse practitioners. This procedure involves sticking a needle into the small pericardial sac that envelops the heart. The procedure is performed on patients who are preemies or premature infants weighing less than 1 pound, and the heart is somewhere between the size of a grape to a walnut. If performed incorrectly, the heart may be lacerated, air can be introduced into the heart, resulting in death. There can be bleeding, infection, and arrhythmias. As practice has changed over the years with advances in care, this procedure is no longer needed to be performed on a regular basis. And in fact, it has not been performed in the NICU at Valley Medical Center in over 10 years. It was therefore felt that this should not be part of the core privileges. To your point and question, in the last few days, we've heard that at least one nurse practitioner who has expressed interest in reserving the ability to perform this procedure should the need arise. The NICU staff is reviewing the type of skills and training that would be needed for those neonatal nurse practitioners who would like to obtain this privilege to do this procedure as a non-core privilege. Once the medical staff can develop the competencies and skills training needed to ensure safety, this procedure can be added back as a non-core privilege and brought back to this committee for approval. At that time, any nurse practitioner who wants the privilege can apply for it. From the medical staff standpoint, we look forward to partnering with the neonatal nurse practitioners on this issue so that we all can continue to work together to provide the safest and best care for our patients. And so at this time, we are asking the Health and Hospital Committee to approve the privileges as submitted.
Thank you, Ms. Karanis. So in that sense, this procedure is only being able to be conducted by pediatricians or the surgeons, but not the nurse practitioner. Am I correct?
So in the event of an emergency, the nurse practitioners could perform this procedure as under our bylaws. If there is an emergency situation, any licensed independent practitioner, both allied health and medical staff, can perform whatever procedure is necessary to save the life of a patient.
Okay, so basically what we are taking away is that under the non-emergency situation where you can actually schedule it, this is something that would require further study or and it won't be automatic, correct?
So yeah, in the non-emergent situation, we would hope that those with more expertise in this area, other folks within the hospital system, from interventional radiologists to pediatric cardiologists, would help participate in the care, given that this is such a rarity now.
Great. Thank you, Ms. Karanis. And that's all the questions I have for this one.
Thank you.
Thank you.
Thank you, Supervisor Lee. Thank you, Dr. Karanis. Let me just ask the clerk if we have members of the public who would like to speak to this item.
We do have one speaker, Mr. Chair.
And let's hear from that speaker. And just for the record, we allow up to 2 minutes on agendized items, and we welcome our speaker. go right ahead.
Our next speaker is RNPA. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking. RNPA, are you there? You are unmuted, but we are unable to hear you. Looks like there might be a connection. Oh, there we go. Go ahead.
Hi, this is Maria Cortez, neonatal nurse practitioner and also treasurer at RNPA. I am one of the nurse practitioners who this is going to affect. I was also involved, I just want to let you guys know, I was involved when the nurse practitioners reviewed the privileges. There were some changes that needed to be made that were completely necessary. There was an oversight in the fact that the pericardiocentesis was removed. When the review actually came to us, the error was that we ended up with the simple markups and not the complex markups. And so it was not clear that it had been crossed out. I did touch base with my medical director, who admitted it was also an oversight. We had discussed at that point about being able to maintain the skills. And the neonatal nurse practitioners do actually practice the skill in simulation. The last time we actually went over the skill was in 2019. And we did it on fetal pigs. We are the only providers in the NICU, and that includes the hospitalist and actually, as I've learned, even the neonatologist who actually perform and maintain competencies in pericardiocentesis. The reason I'm so opposed to having it removed is having the privilege added back later seems to be more complex. It often involves the nurse practitioners having to explain their scope and what they do. And so I would like you guys to consider sending it back for a revision. I understand that it went through a very lengthy process, but I think if we're going to renew the privileges, we should do it right. And as providers who respond to emergency C-sections, we respond to all these deliveries, and it's not just the 1 pound babies, it's the much older babies as well who could potentially have this issue. The only other option is to allow death. And obviously we're not going to allow that to happen. We will do it, but it creates a liability when you removed it from our privileges. So please reconsider.
And that concludes our speakers.
Thank you very much. Supervisor Lee, any other follow-up comments or questions?
Yes, so Ms. Karanis, I just heard the comments of the representative who just mentioned that issue. Do you have any responses to how we might be addressed? First is about some of the issues. I guess there's some potential changes, the use of oversight, but is there something that still needs?
I'm sorry, I didn't hear the very last part of what you said. Is there something?
Is there any other changes that still needs to be made? So apparently, based on the earlier speaker, there are still other things that might need to be revised based on what's been proposed. I just want to make sure that we do have a final product, or if we might actually need a little bit more time before it comes back to us to actually get approved.
At this point, we feel we have a final product, and we are asking for approval of this product today. And just in response to the comments that were made earlier, as I stated before, that we do have the provision within our bylaws for everyone to do everything possible under their license to save a life. And so that there would not be the options that were discussed or mentioned.
So Ms. Karanis, if we postpone this to next meeting for approval, do you think you could actually get this resolved? Because I really don't want to have our own nurse practitioners to walk up here as if we did not listen to them or make these changes they've requested. And I'm wondering if a little bit more time would be helpful to have more dialogue between all the parties so that we can have a more complete product.
If we to make any revisions to the document, we'll need to go back through all of the processes that were outlined above earlier. So it will take several months for that process to occur. And we are expecting a joint commission visit in the fall. So that was one of the reasons to well, we are expecting a joint commission visit in the fall and need to have these updated privileges in place.
Dr. Kranis, this is Supervisors Committee, and let me ask a question. We have, as you know, under item number 4, 4 possible actions for A, B, C, and D. Does the do the privileges and position or positions that are at issue here, are they limited to just one of these 4 items?
Yes, they're just listed under, it's limited to the enterprise pediatric NP privileges.
Supervisor, can I jump in for a second?
Sure. Thank you, Dr. Smith. The question I was about to ask, if you'd like to cover it as well, was is it possible that we could take action on items A, B, and D? A is in apple, B is in boy, D is in dog, A, B, and D, and continue C. That would address, I think, the desire of Supervisor Lee to spend a little more time looking at that set of issues while still allowing folks to move forward on the other 3 larger sets of authorizations. To you, Dr. Smith. Thank you.
Yeah, I would advise the board to move ahead with the approval of everything, because I think the distinction that is important to realize is we're talking about core privileges, meaning that anyone who is a member of that particular classification in the medical staff has the privilege of doing the core procedure. What Dr. Kranis is talking about is that this particular procedure is particularly dangerous and requires training. And the fact that nobody in the nurse practitioner class has done it for 10 years indicates clearly that nobody currently has sufficient training to do this severely dangerous procedure. And what the medical staff will do is develop another track where you can add to your core privileges, new privileges. They have special training to do. So for example, even a licensed physician would not be able to do this procedure if they did not have appropriate training to do it. So I think rather than having the committee delay, I think you should move ahead with the approval because it is very important to accreditation to have approved credentials with demonstrated proficiency. And I can assure you that without this, we'll get a ding on our JCO review.
Dr. Smith and Dr. Kranis, did I hear, however, that if we did approve all 4 of these possible action items, that there is a path toward providing some kind of credentialing or privileges that is still under discussion or review, and that you could come back to us at some point in the foreseeable future with an approach to address that issue?
Yes, that we would look into creating the competencies and skills required to ensure safety with this privilege. And then, as Dr. Smith mentioned, bring it back as a non-core privilege, which would come through this committee again for approval for those individuals who wish to do the additional training and maintenance of that skill set.
And that would take us roughly how long? How many months are we talking about, if I may ask, Dr. Kranis?
4 to 6 months.
So before the end of this
actually, I should say that would be closer to the 6 months, because we still need to do some research on how to implement the competencies, since this is so rarely performed. Again, not in over 10 years, that how do we ensure that competency?
Yeah, okay. Dr. Kranis, this is Douglas Press. Would you also, oh, sorry, if I may, Supervisor?
Please. Go right ahead, Mr.
Dr.
Press.
Kranis, could you please speak to the issue about the fact that these new enterprise privileges will only take effect upon reapplication? And so if someone has their existing privileges for this procedure, that will still remain in place for some period of time. Is that correct?
Yes, that is correct. So we've been implementing these new privileges in a rolling format. So as people come up for reappointment, then the new privileges get instituted at that time. So for many individuals, this will not go into effect for almost 2 years from now. For them, if they have just been reappointed recently, which is the case for at least one of the neonatal nurse practitioners. So by the time they would come up for reappointment, we should have this process fixed and they would be able to apply for that privilege were they still interested and had the necessary competencies.
Thank you.
All right, thank you very much. Supervisor Lee, the action of the committee, of course, requires a majority vote. Majority vote of 2 members is 2 members. And so I am comfortable approving as recommended item 4, A, B, C, and D with a report back on the process that Dr. Karanis has described prior to the end of this calendar year, meaning in 2021. Dr. Karanis, that's 6 months plus, and we would expect to hear back on that item. If you're prepared to make that motion, Supervisor Lee, or to support it, if you would like me to make the motion, then I would suggest we proceed in that way. If you are not, notwithstanding the recommendation of staff, then I would suggest we could and should at least take action on items A, B, and D. What is your preference, Supervisor, if I may ask?
Thank you, Chair Simitian. I think that's a very reasonable move. We certainly want to protect the safety of our babies and to make sure that those who are performing it has the right credentials and training. So we could create like a deadline, like say end of this year, I think 6 months, right? 4 to 6 months, so 6 months to make sure these competency creation is being done. I think that would be definitely doable, especially the fact that these privileges are not going to be expiring immediately, but for upon the reapplications of a year now. So by then that should be fixed. So I think that's a good compromise to keep that moving forward. I appreciate it. And I apologize.
All right.
I'll address you properly. I didn't see your doctor before your name there.
It's
So,
quite
my
all
bad.
right. And thank you very much. And yes, we'd be happy to come back by the end of the calendar year with an update on the progress and hopefully even for an approval for those changes.
All right.
And if I can just make one, there's 4 items for the approval. There's A, B, C, D, E, and F. I just want to make sure that was all seen. The robotic thoracic surgery privileges for O'Connor Hospital as well.
Correct. Yeah,
Doctor, you confused me there just a little because I heard A, B, C, D, E, and F, but I also heard 4 items, and A, B, C, D, E, and F would be 6 items. So I just want to make sure we're talking about 4 items, A, B, C, and D, yes?
I'm sorry, it's actually, there's 3 items that are there, that there's the final and the red line version for a total of 6 items, A, B, C, D, E, and F.
All right. Thank you for that clarification. All right. So Supervisor Lee, motion by you. Yes, sir.
So moved. Yes.
All right. And a second with the direction to return no later than the end of this calendar year as to the issues raised around privileges. Then we'll call the roll just for the record, please.
Vice Chairperson Lee,
Yes.
Chairperson Simitian.
Aye. Motion carries 2-0. Thank you very much. Thank you all. We'll go on to our next item.
Thank
That
you.
takes us to item number 5. And this is the report from Facilities and Fleets regarding the Child and Adolescent Psychiatric Facility and Behavioral Health Services Center. Who's going to present on this item, please?
Supervisor Simitian, this is Jeff Draper, the Director of Facilities and Fleet, and I'm going to let Doug Koenig, our Deputy Director for Capital at Hospital Projects, report to you.
Go right ahead, sir.
I'm sorry. Good afternoon, Supervisor Simitian, Supervisor Lee, Doug Koenig with Capital Programs. I have a couple of updates to the report that you have before you. First, we've been talking about collaborative review with OSHPD. That process has started. The design and construction team has had the opportunity to meet directly with the OSHPD review staff to review increment 1, which is the foundation and structural package. It's been a great process, very helpful. The design team can get immediate clarification on review comments. They can also mutually discuss resolutions to any issues that have been brought forward. So that we think that's going to smooth the process and result in a quicker review and a quicker approval of the packages. Also, another major milestone we've completed, staff has completed our recommended CEQA document. That will be presented to the board for adoption at the next meeting on May 4th. Assuming that would be adopted, there's a second item on that agenda to increase the value of the CMR contract with XL Construction, as our efforts to expedite this project are moving some of the costs from the construction phase into the pre-construction phase. Lastly, just as a heads up, given an approved CEQA document, we would expect in the next 4 to 5 weeks to issue 2 notice to proceeds for construction activities. The first one would be for the make-ready work for the Behavioral Health Services Center itself, which would include the demolition of parking structure 3, as well as the excavation for the foundation and basement for the BHSC. The second notice to proceed would be for the demolition of the Della Maggiore Center and also for the construction of the replacement parking structure at that site. That concludes my comments. Are there any questions?
Supervisor Lee, any questions?
Not really. I did ask for earlier, Mr. Koenig. Let me ask this a quick question. We talked about having the ability to have some visibility from the top floor or that balcony area and on the very top on the roof area to have some visibility to down below. And they were talking about putting some type of maybe glazing material for the construction. I'm not sure if that's been mentioned now or been revised to incorporate some of those features.
I'm not sure I caught the question.
Am I too soft here? Let me try to be louder. I apologize. So the question I have is regarding the actual building on the rooftop area, because of the fact that previously there was no way to look out of that area.
Right. Okay.
So I asked if we could put some glazed glass material to allow some visibility from the top and don't feel so constricted.
Okay, and I guess I could share my screen. I did send this to your staff earlier this morning. Perhaps I didn't get the opportunity to see it. But if I hopefully, can you see the screen showing a basketball court?
Yes, I can clear it.
Okay, if you notice that the design team took your comments back, and they did work to improve the ability to see out of the structure. They've added 3 windows here on the side of the basketball court, and let's see. And this would be the view from the interior of the basketball court, showing the location of the 3 windows. So, hopefully that addresses the comments that you had and the recommendations that you had.
Yeah, no, thank you. I think it's good to have at least some visibility. So I think that would improve the viewing or the feeling of the space. So thank you.
Okay.
Thank you, Supervisor Lee. Mr. Koenig, let me just ask, mindful of my recurring questions about timeline, I noticed there's been a slight change in the language of the project schedule. At one point, we were talking about opening in November. Then we were talking about construction through November of 2023. Thank you. And now we have staff and stock after construction, which is indicated as November of 2021 through August of 2023. Let me just ask, what's happening there? What's going on? Just so I understand a little more fully, please.
I think when you're talking about staff and stock and as we try and move to serving patients by November of 2023, one of the things we're going to have to do is staff and stock the facility so that the actual beneficial occupancy, whether that's the entire facility or by floor, as the contractor has advised us, they're going to be starting on the 3rd floor and working down. If we can, our intent would be to take beneficial occupancy of, say, the 3rd floor and follow them down. And as we do that, staff and stock and get prepared for the licensing by CDPH. So what we're going to have to do is they're going to have to complete their in order to meet this schedule and in order to start serving patients, we're going to have to move up the beneficial occupancy date of the facility. And that's something that we're coordinating with Excel to do everything we can to try and meet that date.
Okay, and you've shared with our committee previously the incremental process with OSHPD to try and facilitate step-by-step incremental construction progress. And there's an indication here at packet page 39, which is page 2 of 5 in the staff report, that there have been recent meetings with OSHPD. I'm noting one as recently as April 7th of this month. How are things with OSHPD? Let's try it that way. Let me just give you an open-ended question.
But it's the collaborative review meetings have been taking place. We've had 4 so far, 2 of them on the first package being the critical one, because that's when we'll get our plans approval for the foundation and the structural system, which is the critical path to getting this project complete. There have not been significant comments that have come up. There have been no stoppers. The structural team on the AE side seems to be able to work out the issues that have been raised with the OSHPD reviewers. And I think that the process is going to go well, and it's going to get us an early plan approval for the first increment.
Great. All right. And are we positioned to move in a timely fashion if we get an early plan approval so that we don't have an approval that we're not acting on?
We've got the CMR, Excel Construction, has already bid out the packages, but based on the design development drawings, not the 100% CD drawings. But there is already a structural steel fabricator that's on board and under contract. There is the foundation, the contract for the shoring and the excavation has already been let. They've only been given the authorization to proceed with the design assist and delegated design type activities, but given plan approval, it would be a quick modification of their contracts adjustments as far as cost, but they should be able to react very quickly and mobilize and take advantage of the early start.
Mr. Koenig, again, perhaps Mr. Press, and Mr. Press, I understand if you haven't been the construction lawyer on this yourself, but I have had concerns over the past several years that from time to time we have projects where contractors either stop the works or dramatically slow the work, or in some instances appear to go off and work on other jobs, presumably because our liquidated damages provisions in our contracts aren't sufficient to motivate them to stay on time and on the job. Mr. Koenig, you feeling okay about that? Have you looked at those issues with either legal or the construction manager at risk or both?
I feel comfortable with XL. They are definitely working with us. They definitely have accepted the challenge of the shortened construction period. If nothing else, they're pushing us more to deliver their facilities for their construction office, for their laydown areas. So they're working with us, definitely. They've accepted the challenge.
Mr. Press, again, I understand that you personally may not have been involved in these construction documents. Do you have any thoughts about the concern I raised? It is one that is born of experience at the county, I'm afraid.
And beyond, I share your concern. As you surmised, I don't have personal familiarity with the particular damages or other related provisions in this construction contract, but we can give you a short off agenda summarizing those.
I would appreciate that short off agenda, and I would also ask Mr. Press and Mr. Koenig that you sort of give some special attention to this. Gentlemen, I don't want to micromanage your oversight on this, but as I say, I've just been disappointed too many times not to raise it. And so I'm raising it now in the hope and expectation that 6 months or a year from now, we're not having a conversation about a stoppage or a delay simply because somebody had another job they had to hustle off to because they had more incentive to be there than on the job performing per contract in our case. I am anxious about that, want to make sure that we avoid that. So if we can get that off agenda report back, that would be that'd be much appreciated. Okay. And then my last set of questions, as we do each month, I want to run through. I'm looking at the project schedule, slightly revised, but not really as to time as much as to description of activities on packet page 39, page 2 of 5. And so I'm going to ask Mr. Koenig, are we still on track to meet that timeline?
Yes, we are.
Mr. Ohashi, are we still on track to meet that timeline?
Yes, sir, we are.
Mr. Sodi, are we still on track to meet that timeline?
Yes, sir, we are.
All right. Mr. Draper, are we still on track to meet that timeline?
Yes, we are.
Thank you. And I understand Mr. Lorenz is not with us today, but I'll turn to Dr. Smith and say, Dr. Smith, are we still on track to meet that timeline?
Yes, we are, but I do want to also point out, as Doug mentioned, there are 2 items on the board agenda for next Tuesday. I think they'll be numbered number 72 and 73. They're very large documents, but very important. One is a mitigated neg deck resolution, and the other is a project change agreement. Those have to be approved on Tuesday. And if they're not, they will delay the project.
Understood. And Dr. Smith, thank you for that. And on that point, and you want to go to some other member of your staff as well, Mr. Draper, Mr. Koenig, I just want to honor the ongoing concern that was expressed during her tenure by my colleague, Supervisor Ellenberg, about making sure we were staying in touch with neighbors and keeping them fully informed and hearing their questions or concerns if and when they arose with respect to activity on the campus. Is that still something everybody feels is being honored and addressed as we go?
Supervisor Jeff Draper, yes, we've been participating in her neighborhood meetings, and we're fulfilling the information and giving the information that's been requested, as well as additional information about the development of the campus.
Great, thank you for that, much appreciated. All right, then let me check with the clerk to see if we have anybody who'd like to speak to this item.
We do have one public speaker, Mr. Chair.
Let's go ahead and hear from him or her. And for up to 2 minutes, please.
Our next speaker is RNPA. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Thank you, supervisors. This is Alan Kamara from RNPA. In the line of questions that you are asking Supervisor Simedian about if the construction team is meeting with the neighborhood to express any concern, what we didn't hear is how is this going to affect the staff when this parking structure is demolished? As you all aware right now, parking is a crisis at Valley Medical. Eliminating that parking structure, that's a visitor's parking. That means they are reallocating all those visitors in an already stranded parking space that the staffs are using to come to work. Not once did we hear concern if they have met and discussed with the bargaining unit who represent this staff that works at the facilities to make sure their concerns are heard. We are having problems with parking structures. Our nurses come sometimes, especially in the PM shift, it is difficult to find parking. And some of these nurses have to leave like 3 a.m. in the morning. It's a dangerous time when they park far away from the hospital just to make it to work. We're getting frequent parking permits because nurses are parking places that they are not supposed to be parked at. We've raised this concern with the administration. We have yet to receive any answer. So are the supervisors willing to allow this to happen without this parking issues for the nurses being addressed? And we felt it is very important that before this goes on, that you address our concern about parking for our nurses. Thank you.
Thank you. Let me just turn to Dr. Smith and ask Dr. Smith, can we ask you to make sure there's a timely response to the inquiry and concerns that have been expressed around parking issues?
Yes, sir.
All right. And perhaps we could get a brief update on how those issues got addressed as part of the report back at our meeting next month when we take up the monthly report on the child and adolescent psychiatric facility. Would that be manageable?
Yes, we do have a plan to transfer parking. So the plan exists. We'll give you a report back on the next meeting. Yes.
All right. Thank you. That being said, then Supervisor Lee, if you don't have any other questions, can we get a motion to simply receive the report, which is the recommended action?
Yes, so moved.
With the direction as indicated as to liquidated damages and parking issues raised. Yes, for the record?
Definitely, yes.
All right, I will second. We'll ask the clerk to call the roll just so it's a matter of record, please.
Vice Chairperson Lee.
Yes.
Chairperson Simidian.
Aye.
Thank you.
Motion carries 2-0. Thank you very much. Then let's go to item number 6. This is the alcove item, and let me ask who's going to lean in and present on this one.
Good afternoon, Chair Simidian and Supervisor Lee. Sherry Terrell with the Behavioral Health Services Department. We have Catherine Aspiris here from Behavioral Health, Zelia Friacosta also from Behavioral Health, and I believe Mr. Draper is here from Facilities and Fleet to answer any questions you may have.
All right, let me start by seeing if Supervisor Lee has any questions.
Yes, thank you very much. Good report. And I would like to also check on the hiring of the individuals. I know as far as the schedule is concerned, I'm sure Supervisor Simidian will be asking those, so I'll leave that to him. As for the hiring of the individuals, I know there's a discussion of hiring a program manager, 2 clinicians, and some health services representatives. Looks like those are all happening simultaneously, and it looks like we have some good news. So I just wanted to give some quick update, Ms. Terrell.
Sure. Catherine, you want to go ahead and provide that update?
Sure. Good afternoon, Chairperson Simidian and Supervisor Lee. To provide some updates regarding the hiring for the behavioral health services staff, we have interviewed and offered a position for the program manager 2 position, and he did accept the offer. He's currently going through clearances and health screening, and then we will hope to onboard him soon. We also did extend 2 offers to the behavioral health clinicians. We did interview the clinicians last week with the Youth Advisory Group and our partners at Stanford. And both clinicians have accepted the offer, and one will start on May 17th, pending all the clearances and transfer plans. We are still working on hiring the HSRs, but we will focus on that right now. And then we have one additional clinician we will be hiring for, so we are recruiting for a bilingual clinician.
Great. So with this schedule, in terms of the offering and hiring, are we still on schedule in terms of opening the facilities on the basis of staffing?
Yes, so the staff will be ready and trained, and will be ready by the end of June. One of the clinicians is actually internal, and so it'll be a great support to implement the clinical workflows and support in moving forward with the implementation.
Great, thank you. The second question is regarding the data collection systems that was mentioned of the discussing using the My Avatar to collect the information. Now, Stanford is working with this thing called Data Cove. I just want to make sure that they'll be able to talk to each other, or are we going to have some issues regarding that?
So we don't have any updates regarding Stanford's system that they are calling Data Cove. It's through another organization. At this point, we don't anticipate any issues with the data being collected in My Avatar system and possibly sharing data once we understand what the program is going to need on the Stanford end. So but we have discussed not interfacing our systems, so we'll need to kind of develop and work around that.
Okay, good. Yeah, I just want to make sure we are planning for that in case there's any workaround that needs to happen. And with these alcove centers going to be open pretty soon, right? When do you think will the workflows and processes for the medical services be completed? And do you think your department would need any additional support to create these workflows?
So we are partnering and meeting with Valley Medical Center as well as the Stanford physician that will be contracted through Lucille Packard. We do meet with them twice a month, and we are going to be working on the development of the workflows to ensure that there's a warm handoff between the different providers in the center and that there's no duplication of data gathering or information gathering. So the physicians are a part of this process as well as the behavioral health team to develop that workflow.
Great, thank you. And that's all the questions I have.
Thank you.
Thank you. Thank you, Supervisor Lee. Thank you, Mrs. Barris and Mr. Rao. I just want to nail down the start date, the opening date, because we've been chatting a little informally about June, end of June, but I still have June 25th as a Friday start date at the as the time to which we are committed. Is that still a correct assessment for both sites?
Yes, it is.
Great. And Mr. Rao, is that your understanding as well?
Yes, it is, Supervisor.
And that's Mr. Rao, and Mr. Rao, I'm smiling at you as I say, yes, I am putting you on the spot on purpose here. So I just, you're feeling like, based on what you hear from both the facilities and fleet folks, and in terms of hiring, that both sets of issues will be resolved that allow for that June 25th start date, yes?
Yes.
Okay, then let me turn to Mr. Draper and say, Mr. Draper, how are you feeling about that June 25th start date?
Good.
Good, all right. Then plan to see you there. Thank you. All right. Supervisor Lee, thank you for your questions. They mirror my own interests and concerns. So if you want to simply move the recommended action, I will second. Then we'll see if we have any members of the public who wish to speak to this item. I'm sorry, Supervisor Lee, you're muted.
Oh, I'm so sorry. I made my motion muted, right? Yes, absolutely. It's definitely support the motion. Thank you.
All right, thank you. Motion from Lee, second by Samidi. And let me just confirm with the clerk. Do we have any speakers on this item?
We have one speaker, Mr. Chair.
Let's hear from him or her, please.
Our next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Hello, good afternoon, everyone. Scott Largent.
Oh, we seem to have lost Scott. One moment, please.
Could we reset Mr. Largen's time? Thank you.
Absolutely. I'm sorry. I accidentally promoted him. Give me just one moment. Scott, hold on for just 1 second. We're going to change it back to an attendee. All right. Thank you for your patience, Mr. Chair. Sorry about that. We'll go back and we will unmute Scott again. Scott, you've been unmuted. You have 2 minutes to speak. The timer will start when you begin speaking.
Okay, good afternoon, everybody. Almost got the green light to talk whenever I want to. So that might have been a big mistake right there, David. But guys, what I'm getting at, I got a little sidetracked. I was on another project. I kind of listened into the meetings, and you guys know my same old thing that I keep talking about. Do we put something in place temporarily right now as we wait to erect all these new buildings that are going to be the latest and greatest? You know, what's a good way to get your guys' attention? Every Sunday, I mean, I volunteer almost every day, but every Sunday I serve coffee and food out at St. James Park with Trinity Church there. And it has gotten so out of control out there with people that have severe brain disorders, meth addiction, you know, whatever it is. I am amazed that in Silicon Valley that we allow people to just exist in the elements like that. They're a danger to themselves. They're a danger to other people. Why don't we care for people like that? Why don't we care for the elderly, the disabled? How else do you explain it? Where are you guys at? And I know COVID, you know, I get the whole COVID thing, but is behavioral health on Santa Clara Street still working from home? These people needed our help. And prior to COVID, it was really bad already. You know, in elementary school, when the schools got packed, we started putting in trailers and extra buildings to accommodate the need. We have a need. And I worry that we're not doing anything about that need. You guys can come out there when we're serving coffee out there and just watch. It's shocking. It's everyone out there is absolutely just, you know, I'm very frustrated. Thank you.
That concludes our speakers.
All right, we have a motion and a second. We'll ask clerk to call the roll.
Vice Chairperson Lee.
Yes.
Chairperson Simidian.
Yes.
Thank you.
Thank you very much. And for the record, that was item number 6, which has now been approved unanimously. And that takes us to item number 7. And let me ask who will be providing the presentation on the Asian and Pacific Islander health assessment update.
Hi, this is Rhonda McClinton Brown here. I don't have a presentation for you today. I'm here to answer any questions that you might have of me.
Thank you. And if I could ask either you or Dr. Smith or some combination of the two of you to just clarify how, when, where we expand our efforts, what's described as budget and transition plan from phase 1 to phase 2. I have it in front of me, but I'm just trying to sort of say how, when, and where does that happen again? Could I get a little more detail on that?
Sure, Supervisor Simidian. I'm going to let Dr. Jeff Smith do that unless he would like me to chime in. But before I turn it over to Dr. Jeff Smith, I want to acknowledge and apologize to you that we had your name misspelled in the previous ledge report file. And I just want to publicly apologize to you for that and make sure that we don't do that moving forward.
I have been Semition, Semitan, Simitane, whatever you do with it, it's not going to be a bother. No worries. But it's kind of you to take that burden on. But the least of our worries, I think. Dr. Smith, how are we going to get to these subpopulations?
Your question is about the budget transition, if I'm understanding.
Yeah, we you know, some of this got delayed, and so we're moving from what might be called a pilot, to a sort of a full implementation of the program and the executed agreement. So are all of the subpopulations planned for, I guess, in the proposed budget that we're going to be looking at in May and June?
We will have sufficient allocation in May and June to continue with the program and cover all of the planned populations, subpopulations. Yes,
Okay.
and as you know, we do yearly budget approvals, and this project will be funded as completely as it needs to be.
Okay, thank you for that. Ms. McClinton Brown, anything else you want to add to that?
No, I don't think there's anything else. We are moving forward with implementation, and Aki has been very gracious to work very closely and collaboratively with us so that we'll be able to provide you monthly updates moving forward. The contract is fully executed, and they are moving forward with training plans at this moment in time.
Great. All right. I have no other questions. Supervisor Lee, comments or questions from you at this time?
No, I just wanted to thank Rhonda for the good work and working with Aki, which of course has been a organization for half a century serving the Asian American community in so many ways. So I just want to say thank you for that.
Thank you.
Thank you. Do we have any speakers on this item? Looking to the clerk.
We have no speakers, Mr. Chair.
All right, then Supervisor Lee, can we get a motion to receive, which is the recommended action?
Yes, motion so moved for received report.
Thank you. And I will second, and let's ask clerk to call the roll just for the record.
Vice Chairperson Lee.
Yes.
Chairperson Simitian.
Yes.
Thank you.
For the record, the motion is approved unanimously. Thank you. Takes us to item number 8, which is our monthly COVID report. And let me ask through Dr. Smith, if I may, who'll be presenting on this item? Do we know?
Good afternoon, Supervisor Simitian and Supervisor Lee. This is Dr. Sarah Cody, and I will be presenting in collaboration with Dr. Fensterscheib, and Dr. Smith is running the slides for us. So today, thank you. Today we are going to give you an update on, just a brief update on the epi trends, as well as an update on the rollout of the COVID-19 vaccine. So on the first slide, you can see our epidemic curve since the beginning of the epidemic. And what you'll notice is that our case counts are flattening, and they've actually been pretty flat since about mid-March. And for the last 2 days, our new cases reported were in the double digits instead of the triple digits. So a little early to call it a trend, but at least we can say that cases are flat. The next slide are our hospitalizations, and they are really starting to stabilize at our pre-surge level. That's by surge, I'm referring to the winter surge. They're not quite down to where they were before the summer surge. They're still at about twice where they were at the summer surge. But they are flat to, maybe even drifting downwards. And in the final slide of the epi update, you can see the deaths by week, and thankfully COVID-19 deaths continue to decline. So now we're seeing around 20 deaths per week, which is right around what we've experienced for most of the months of the pandemic, apart from the devastating surge in the fall and winter. With vaccines rolling out as they are, we hope and expect to see the deaths from COVID to drift down further, but time will tell. So next, we're going to just provide a brief update on COVID vaccines. And I'm going to turn this over to Dr. Fensterscheib.
Thank you, Dr. Cody. And so we have just a few slides for you today. The couple things in particular, the Johnson & Johnson vaccine, as you know, was on pause. And now that the FDA and the CDC have reviewed through their committees the data on the number of cases that we're experiencing that significant but rare blood clot condition, they have released the vaccine once again and resumed that pause. So now the vaccine is now available. We have we have the Johnson & Johnson vaccine on hand because, again, we had it when the pause occurred. We are just waiting to finalize some of our fact sheets and get them translated because we feel it's very important, again, to be able to provide the information to those that may want the vaccine. We will always give someone who doesn't want that vaccine the option of receiving either the Moderna or the Pfizer vaccine, but we will have the vaccine at those sites, including the Johnson & Johnson, if on demand the patient would like and request the Johnson & Johnson vaccine. Again, who is eligible? Everyone is eligible, and you need to live or work in the county. So let's move on to the next slide. I think that's a snapshot. So this is our latest snapshot, and we're doing very well. Of course, we're over 1 million first doses of vaccine. We're just at about 66% on our way to 70%, and doing very well on the completion of vaccine, also at 38%. Our no-show for second doses rate is pretty small and low, and we will be following up on that, but it's about around 8%. The issues of disparities are still significant, and on the next slide, we can see the specific breakdown by age and eligibility, and also by race and ethnicity. And so on the top, for everybody 16 years of age and older, again, there's that 66%, but you can see how that breaks down by race and ethnicity. We are doing better than we have been. The Asian population is far and above, out in front as far as getting themselves vaccinated. And then the Latino population is at about 41%. So working very hard to close that gap. If you look at the 50 years of age and older, again, the numbers across the board are looking very good at 74% total, which is great. And then you can see the breakdown for the race and ethnicity. Again, the disparities, but the Latino Hispanic population is right with the African American at 58%. And so again, there is improvement there. And let's move on to the next slide. And so this slide is showing you the age breakdown, and I'm just going to move the pictures out of the way so I can see it. I think really what you're seeing here is the older age range at the top, which are the senior citizens. The curves are kind of flattening, meaning that there's a slowdown in the population coming in who are seniors. At the bottom there, you can see the youngest age groups between 16 and 29, and those slopes are much steeper, showing you that that's the population that are taking advantage of the vaccines, and larger numbers obviously are coming in to be vaccinated. Next slide. And this is basically showing you, again, for residents, this is now age 50 and above, and breakdown by race and ethnicity. And you can see, again, that there is kind of a clumping together in the population, the white population, African American, and Latinx population, kind of clumped together there between 58 and 60%, which is great. And then the Asian population, which is up at 82%. Next slide. And this is just a breakdown of vaccinations age 50 and older by county region. And again, a lot of clumping for most of them, but you can see some of the northern regions of our county are at higher levels. So, but everyone is doing pretty well. If you look at the numbers, all of them are rather high. And I think that may be our last slide. Again, the information is on our website. We now have, of course, the links to the retail pharmacies on there also, and more vaccine is coming in through the retail pharmacies. We have well over 125, I believe, retail pharmacies. The federal government is really trying to bring vaccine to local communities through those local pharmacies as well as the FQHC clinics. So I think that's the wave of the future. The only other update is that we expect that the FDA will approve the request for an amendment by Pfizer to expand the utilization or eligibility of the Pfizer vaccine to the 12 and 15-year-olds. And I think we'll probably see something in that regard sometime in the next couple of weeks into May. So that will expand eligibility then from 12 and older. So that would be the end. I'll turn this back to Dr. Cody.
We're happy to answer any questions that you may have.
Thank you very much. And forgive me for having my screen off. I've got some bandwidth issues here, I think, technologically, but we turn to you, Supervisor Lee, and see if you've got questions. I know I do. And at some point, Mr. Clerk, of course, we will, of course, want to ask if there are members of the public who'd like to comment. Go right ahead, Supervisor Lee.
Well, thank you, Supervisor Lee. First of all, thanks for the really good news report from Dr. Cody and Dr. Fensterscheid for all your amazing work in our team's delivery. We've certainly ramped up our delivery significantly, especially since a couple of weeks ago when we got the last batch of vaccines and also the opening up of 16 plus years old, being everybody qualified to get the vaccines. I know we were talking about having the rate of up to close to $200,000, excuse me, 200,000 vaccination doses a week. Are we getting pretty close to the numbers now, number one? And number two is, are we actually getting some openings? Because I've been hearing saying that these slots are not taken out, so there might be almost to the point where less people are signing up than the available appointments out there. Are we seeing that?
Yes, we're seeing what some other communities around the Bay Area have seen, in that it's a very dramatic issue of demand exceeding supply, and then it changes rather abruptly to supply exceeding demand. And so we're just beginning in that phase. So we do have extra capacity. And I think that the work ahead of us is expanding much of the work that we're doing already, which is to do very intensive outreach to reach people who've not been vaccinated and ensure that they get vaccinated and to understand any barriers they may have to vaccination.
Right. Thank you, Dr. Cody. And on that note, we've been talking about increasing the number of hours, like after hours and evenings, on the weekends. And do you have any data as to how are we doing on that? And are those being very receptive to the communities?
Yeah, what we're learning is that in particular communities, so particularly in the East Side, having evening hours is quite important to the community. And to that end, next week, our expo site at the fairgrounds on Tuesdays and Wednesdays will be open until 8. We're also working to extend evening hours till 7 at Emmanuel Baptist Church for some weekdays. I think that Eastridge now will have both walk-up and appointment-based clinics to provide a bit more flexibility. And lastly, our mobile MOVAX team, the mobile vaccination, they're going to be increasing their weekend availability and also do a few evening clinics during the week. And that's going to start next week.
That's wonderful. Thank you. I've also heard that since there are quite a few people, some of the appointment sites are not necessarily that full. Is it true that some of our appointment sites now are all becoming both appointments and walk-ups as well?
Yes, we've converted to having a combination of walk-up and appointments, and I think the word is still getting out. So I believe I heard that it's in the 100 or 100 plus walk-ups to some of our larger sites.
Yeah, I would just add that we have, for this week until Sunday, all of our sites except the fairgrounds are all walk-up. You don't need an appointment for any of those sites, and so we're seeing a good utilization. And the Levi Stadium is appointments, same-day appointments. So we've been messaging that out to the community that people, even though we don't have walk-ups at Levi's, we have same-day appointments. So you can get one for today, just go online and get an appointment for today.
Great. At this point, I think the issue I have mentioned previously that I'm worried about this vaccine hesitancy might be our next barrier, in addition to the access issue for some folks who might not have transportation or hours. So regarding the vaccine hesitancy, I just want to find out more if there's anything that we've been able to start or gain in terms of messaging out to tell people the safety of the vaccines. And of course, with the Johnson & Johnson vaccine, being recently approved, that hesitancy issue, of course, will need to be addressed. And have we had people coming up and basically say, I don't want this vaccine, I want that vaccine instead of that type of situations?
Well, we, as I think many jurisdictions are offering choice. So it's a choice between a 1-dose vaccine or a 2-dose vaccine. And we've also produced, or in the process of producing, some really simple, easy to read materials to explain the vaccines. I think that vaccine hesitancy, reasons for hesitancy, are not uniform, and they are different in different communities. So we have, some sense in some communities, but I don't think that we have a comprehensive understanding of all the different issues at play, and more importantly, what are things that we can do to help resolve them. What would you add?
I think we've heard a number of things where we're doing these types of door-to-door educational sessions and trying to find out exactly what these hesitancies are from. And people, it's all over the place. I mean, some people feel, and a lot of our communities have had COVID already, a lot of the members, and they're saying, well, I've already had it. I don't want the vaccine. I already went through all of this, and so I don't want it. Others are worried that the symptoms of their side effects are going to be worse than getting it. Others have told us that they're concerned of crazy things like fertility issues, which have nothing to do with the vaccine. So there's a lot of misconceptions out there. And so that's why it really is this. I think the push for the last 25% or so is going to be really difficult because of the hesitancy issues and trying to deal with a lot of the misconceptions at this point, but we're working on it.
Yeah, so I just think that absolutely, you're absolutely right. I think it's important to have like a fact check or that type of information available in different languages, because people are getting information in so many different places these days. Like yesterday, I remember reading a news article, I'm sure you might have seen it too, some school in Miami, on Florida, that is banning teachers or students or staff members that has received the vaccine from going to school, which is totally ludicrous. But certainly, that's the unfortunate thing is that with a free society we have, there are dumb things or crazy things that's being said out there, like you said about the pregnancy issues or fertility issues. So I just want to make sure that we have those type of materials being made ready, available to help alleviate these type of concerns from people. And I just, and then we'll talk about that more too in the future, because I do really see that the next barrier might be harder, trying to change people's mind to get the vaccine and to really prove to them that this is very safe. Because at the end of the day, without the number of people over, I'll say 80-85%, right, to get that herd immunity, I think we're going to have a hole and that's dangerous, especially in light of what was going on. I mean, we are very fortunate, as you mentioned. We have over, it's like 2/3 of the people now having at least one dose, close to 40% that has 2 doses, which is phenomenal. And no small things to your good work and Dr. Tong and many who's been working on this for so long. But yet at the same time, you turn on TV and see what's going on in India, is truly fascinating because of the number of deaths that's over there. We're not talking about, that we're talking like, the hundreds of thousands of deaths, those numbers that they're increasing so quickly. And then the other issue is the story of how certain physicians, I heard today it was like 37 physicians who were supposed to be double vaccinated, actually did catch COVID as well. So again, a lot of this is preliminary data, but at the same time, we certainly want to make sure that we get vaccinated, and we'll have to find out these new mutations and how effective our vaccination is going to be. And so I think it's so important to make sure people understand that this vaccination is not something nice to have. It really is essential for everybody's public health. So I just want to say thank you for all your great work continuing on this. And my last question is really regarding the guidance we got yesterday from the federal government that says folks now can not necessarily have to wear the mask when they're outdoor in non-congregated setting if they're vaccinated. I certainly think there's probably is quite safe in some of these situations, but at the end of the day, I personally am not going to take off my mask because I think, just to be safe for everybody, I think it's never too safe. Number one. Number two is, as far as I know, I don't care what variants they have. I think by doing what we've been doing in terms of vaccinations and doing the masking, social distancing, that could protect ourselves against any variants. So I just want to see if you agree with those comments.
Yeah, the CDC did put out their guidance for people who are vaccinated, basically giving a bit more latitude, more activities that you can do. The state has come out and said that they, will have more soon, but support the common sense approach. And I would say I support it too, but with a little caveat, sort of the when in doubt, wear your mask. So yes, if you're indoors and you are fully vaccinated and you're certain that the other people that you're with are fully vaccinated, yeah, safe to take your mask off. I think there's a lot of times when it's difficult to know the vaccination status of the people that you're with. And so then you obviously all need to have your mask on. There's also other loosening as far as travel and testing. And I think that these are good. They are, once you're vaccinated and once the community is vaccinated, then we can ease a number of the restrictions that we've all been living with. And this is a nice beginning. So we'll try to put something out locally to make it's a bit complicated. So we're trying to see how we might simplify and communicate for our community.
Thank you very much, Dr. Cody. And that's all questions I have, Chair Simitian.
Thank you, Supervisor Lee. Let me just begin by looking back to the charts. Thank you all. And just an observation more than anything. And I just, if there are any reactions, happy to hear them. I was struck looking at pages, forgive me here, the pages 8 and 9 that are of the PowerPoint that address the percentage of residents at various ages who've received at least one dose. And I couldn't help but note that the folks in the 65 to 74 range or the 75 plus range, both of those ranges hovering around 77, 78%, if I'm reading page 9 correctly. And Dr. Fensterscheib, Dr. Cody, Dr. Smith, anyone, on the one hand, I think, well, that's, it's a pretty good number. On the other hand, I'm struck by the fact that these are the folks who are most at risk of some serious consequence if they do in fact track COVID. And they're the folks that we have been reaching out to and serving for the longest period of time. And we're still at 20+% who haven't received the first dose. Any reaction to that observation? I guess a lot of these numbers are, I think, heartening, but in some respects, I find those numbers not as heartening as they might appear at first blush.
Yeah, you're absolutely right. We always know that with any vaccine, no matter how well you push it out, there's going to be that additional, usually 20% or so, sometimes a lot more, that are just reticent and choosing not to do it. Also, other than vaccine hesitancy, there's also the access issues. So that's why we've certainly continued to go to our senior living centers, long-term care facilities, and the in-home vaccinations that we're doing also. So I think we have to continue pushing, but as you can see that graph, that the numbers really have slowed down quite a bit for those seniors coming in for vaccines. The numbers are really low. So we have to just do an extra push to get that last 15% of them.
Okay. And looking at the percentage, I'm now on page 11 of the PowerPoint. I got a little confusion here, and if there's just a confusion that you should clear up, feel free to help me understand. And if there's an error, I'm struggling with the fact that there appear to be
Or percentage than 100.
Well, that's one. I'm also, let's start with that one since you've called it out. So I think that's the Los Altos, Palo Alto, Mountain View area. That is the light blue line at the top that says 100.8. And as a percent, which is of course mathematical impossibility. So I'm sure there's an explanation. Can somebody help me understand how I should read that number correctly and in context, please?
Yeah, I can try with that. We use the Department of Finance updated projections about population, which is what the state uses and all the other counties use. But of course, those updated projections are not exactly correct. So what this means is that we have more people vaccinated in that population than would be projected by the Department of Finance using combination of 10 years ago census plus new information that's released yearly by the Department of Finance. So it has to do with the denominator issue.
Okay. And I am reading this as providing information for 8 different sub-regions. And I see that there are, in fact, 1, 2, 3, 4, 5, 6, 7, 8 numbers on the side, but I can't see 8 different lines depending on where I look. And is that just as simple as that's because some of the lines are covering up other lines?
Yes.
All right. So that 82.1%, that is a number, a numeral that I can read on the right-hand side. That is the South County number, yes?
Yes.
Okay.
The blue one, yes.
All right. Well, while there's still work to be done, clearly, I gather you are heartened by the fact that the gap between, 80.9 and I'll pick 92.7 for 7 of the 8 groups is not that great relatively from one region to another, yes?
Correct.
All right. Okay, and going back, if I may, Dr. Fensterscheib, to the question I was raising about seniors 75 and above, 64 and above, 65 and above. I'm struck by your observation that the reasons are while there are some that are obviously shared, the reasons are probably a little bit different for every one of those folks who's not yet been vaccinated. And part of the way I'm breaking down the remaining 20+% is folks who are as you've sometimes described them, vaccine hesitant, as opposed to folks who are not finding it as convenient as they would either like or need to get the vaccine. So my question is, could you give us an update on how we're doing with folks who are homebound and or who are not likely to make the trip, whether it's because they don't have transportation or it's just not convenient? I did hear about the extended hours, which I think certainly makes a difference for a group of folks who just couldn't make it during business hours. But how are we doing on some of these other programs to reach people who are absolutely willing to get the vaccine, but just finding it perhaps a little tougher to get access?
Yeah, so this is, you're talking about our in-home program, our homebound program. And so we're working with a number of the fire agencies and our mobile vax unit. We have information on our web. We have a phone number so that we are actively taking names of people that need that type of service and going out. We did have an eligibility. We've basically been talking about just eliminating that eligibility and basically saying anybody that's in need of that particular service of being vaccinated in home will get that. So we're increasing our numbers, working with our partners in fire and different fire agencies. And so we're trying to meet that demand. I think it's a really important one for people that can't get out of their homes very easily anyway.
Okay. Is that program still growing in terms of the numbers of vaccines we can deliver through the program?
Yes, it's growing.
Okay. Let me jump to a topic we've certainly dealt with before, but I'm not sure I feel we've ever wrestled to the ground. I'm looking, Dr. Smith, at the April 22nd, 2021 memo from Key Lee, Nick Burchard, Tim Davis, Eureka Day, Vit Krashar, and dealing with protocols to prevent transmission of COVID-19 in custody settings, report number 5. And I'm looking on page 3 of 4, the Custody Bureau, which is apparently distinct from the Department of Corrections, is indicated as having approximately 1,023 positions, filled positions, and the percentage of folks who have declined the vaccine or declined to disclose or it's unknown is 45%. That can't be a safe place to be in terms of not only their own health, but other folks in the organization. Where are we with this, and is this just something we've resigned ourselves to? Could you bring us up to date, please? At least bring me up to date. Dr. Smith, do we still have you on the line? Can the clerk help me here?
One moment, please, Mr. Chair. We're looking.
I think Dr. Smith had to leave, Supervisor Simitian.
All right.
So, I believe your question is related to the correctional staff numbers.
Well, the question has to do with the Custody Bureau. This is page 3 of a 4-page memo dated April 22nd. And there's apparently a distinction between Custody Bureau and Department of Corrections. Perhaps Ms. Day, Dr. Day can speak to that item. But Mr. Santiago, I more than understanding the number, I feel like we need to sort of wrestle to the ground the question of, so what are we going to do about this, if anything? Because having 450 plus folks in the Custody Bureau who have either declined the vaccine or declined to disclose their circumstances or unknown. I understand it's a complex issue in many respects, but that's clearly a matter of concern from a health perspective. So, Dr. Day, perhaps you can first begin by clarifying what I'm looking at here, but I really am anxious that we sort of say, is that just what it's going to be and we're going to live with it, or where are we here?
And for the Custody Bureau supervisor, I would have to defer to custody. They keep their numbers separate, and how they have their custody colleagues vaccinate is separate than how we're doing it with custody health services. And so I know that I meet with Assistant Sheriff Tim Davis often. Matter of fact, we meet almost every other week. And we do have town hall meetings actually every other week. And we also have huddles for vaccinations, encouraging everyone to vaccinate. And so I think it's partly that folks are basically making personal decisions not to vaccinate. It's not mandatory at this point, although we have put out mandatory testing protocols. However, the vaccinations are not mandatory.
All right. Is Assistant Sheriff Davis on the line with us, or no?
I was scanning the group and I couldn't see him, Supervisor. So maybe what we could do is take your questions and then probably either, whatever your preference, either have a written response in between meetings, or maybe for the next meeting, invite our colleagues from the corrections and sheriffs so that we can get into an in-depth discussion about these numbers.
Yeah. And forgive me, Santiago, because I can't see the full display of the screen. Mr. Marquez with us today? I don't think so.
Yes, Supervisor, I'm here.
There you are. Thank you, Mr. Marquez. And Mr. Marquez and Mr. Santiago, the reason I keep asking is, I know that we're dealing with an independently elected sheriff here, as an independently elected official. Dr. Day, if I understood you correctly, these are custody officers who work in our jail, yes?
These are the custody officers, yes.
Okay. And, Mr. Marquez, the reason I'm coming to you is understanding that you're not the independently elected sheriff. If there's a problem and there's a lawsuit, and there's a multi-million-dollar settlement or judgment, that's coming out of the county. That's not that's not something that is without consequences for our organization. And I just think we need to sort of get a clear answer about, all right, we're more than a year into this. We're many months now into having a vaccine, and we got a very significant number of groups in that arena number of individuals, in that arena, who've said no thank you. And I just think we need to know what our posture is on that, rather than sort of have a report every few weeks that shows a relative lack of movement or progress. So I think, Mr. Santiago, you had a good thought, which is, could we get a report? We have a board meeting next week, I believe. Yes, Mr. Marquez?
Yes, it is May 4th, I believe.
All right, thank you. And we are going to have a COVID report at that time, because we do every board meeting. So I'm going to specifically ask Mr. Marquez and Mr. Santiago and Dr. Day and the Sheriff's Department, I want to be explicit about that, to sort of come to us with a report, not simply telling us what the numbers are, but what the position of the county and the Sheriff's Department is about how to address those numbers. And I'm not suggesting that I have a point of view on the subject. I just think it's time to confront the fact that, we've got hundreds of folks in those positions who have apparently just said no thank you. And we better figure out what the consequences of that are and how we're going to manage it. So is that, Mr. Marquez, do you, understanding that it's a thorny problem, do you feel like you understand what I'm trying to get in the way of a question and answer at the next meeting?
Absolutely. I understand exactly what you're asking for, and we will work with the sheriff's office to see what we can bring back, and whatever we can do, we'll certainly provide it as part of it's at a time certain 1 o'clock report, and we'll include it in that report, let you know where they are, where we are, and see where we go from there.
Yeah, and Mr. Santiago, thank you, and Dr. Day, thank you. As I say, I feel like we've been talking about, but not really coming to grips with this part of the challenge for a long time now. So that's it for me. I don't have other comments or questions at this time. Let me go back to Supervisor Lee, see if he has any other comments or questions he wants to offer. And if not, we will go to the public if we have speakers who'd like to be heard.
Yes, I just have one final question. Thank you, Chair Samidian. It's regarding the kids, or the 12 to 15. So it looks like we are going to have that approval pretty soon from the FDA on the CDC. And I would like to find out what is our plan on that, if there's anything that we need to do different from what we've been doing for the other age groups.
Yes, Supervisor Marty Fensterscheib. So I think because of this age group is used to seeing their pediatricians and their regular providers, and also they probably haven't perhaps gotten all their boosters and all of their health checkups in the last year, that we really are going to be pivoting to onboarding the providers, the pediatricians, the family practices, the community clinics, and really try to get those providers to provide the vaccines to their patients, as opposed to having them all come through a large mega site.
Mm. Okay. Well, with some of the schools opening, we are not planning to do any vaccination on school sites, right?
Not during classes. I mean, we are looking at some of the school sites, especially right now for the 16 and 17-year-olds, and we are going into the communities. We were asking the students and the County Office of Education to help with identifying areas where we can go in and provide special clinics or at least incentives, motivations for the kids. You know, stickers and things that they like that may bring them to be vaccinated. Whatever it takes, we want to get them in there. So,
well, yeah, I just want to find most easiest way for the kids and for the parents, right? If you could get it done at school, then save a lot of trips for many parents to get the kids to whatever the site might be. So
right.
I just thought there are ways that we could make it as efficient as we can. Obviously, with kids too, and you need the parental's permission and all that. So I just want to make sure that we have a good uniform way of doing it. And so I thought, if we have large enough schools, large enough population of showing up to schools, that might be one quicker way to get them to all the kids at the same time. And with the peer pressure too, if kids see other kids are getting it, they'll be more willing. But then if you want to bring them in one by one, they might be, I was afraid of needle when I was little too, so I get that.
Yeah, I totally agree with you. Peer pressure more with the older ones. I think as a pediatrician myself, I mean, I think the parents are going to have a lot of questions before perhaps they're going to okay a 12-year-old to get their vaccine. I think they're just going to want to make sure and trust. We know that they trust their own doctors more than anyone.
That's right. Yeah, good. Okay, thank you very much.
All right, thank you. Let me just confirm with the clerk, speakers on this item.
We do have a speaker on this item, Mr. Chair.
Please go right ahead, and the speaker or speakers may take up to 2 minutes.
Our next speaker is Kathleen King. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hello, this is Kathleen King from Healthier Kids Foundation. Thank you, Supervisor Samidian and Supervisor Lee, for letting me speak. I want to compliment the team that is working on the vaccinations. It's been a very impressive effort with Dr. Fensterscheib and Rhonda and Jennifer. They've put together advisory committees. They've done a great job. We were able to speak on Damien's show in Spanish today to talk about our complimentary hotline that complements the county hotline, 1-833-560-0560. If I can do a little commercial, we have Spanish, English, and Vietnamese. And as of 20 minutes ago, we've have 3,447 we've helped register for their first vaccinations. 41% were Hispanic. And as I said, we were on Damien's show today in Spanish. We're excited about that. We are on quite a few advisory committees with the disabled, nonprofit, and education. We really appreciate that. And we know if we don't get families vaccinated, we won't get everyone back to school. So that is what we're most interested in. We have about 86,000 families in our database, and we're going to start outreaching, and texting, we believe, is a good way to get to families to try and get all the family to get vaccinated. We have some amazing stories about families that have been thrilled to be offered the opportunity to make vaccinations easy for them. So again, thank you, and thank you to the team that's working on this. We get all kinds of good feedback on it. Thanks.
And that concludes our speakers.
Thank you very much. Then if I can get a motion from Supervisor Lee to approve the recommendation, which is simply to receive the report, and with the direction to provide the information at our upcoming board meeting, that would be gratefully entertained.
Yes, so moved, please.
Motion by Lee, second by Simidian. And could we ask the clerk to call the roll, just for the record, please?
Vice Chairperson Lee.
Yes.
Chairperson Simidian.
Aye, thank you very much. Okay, that takes us to item number 9, which is a report from the Santa Clara Family Health Plan. And who will be stepping up on this item?
Christine Tomkala.
Ms. Tomkala, you've been with us from the first moment of the meeting, I know, because I saw you when I joined the meeting myself. So thank you very much, and go to it.
Terrific. And good afternoon, Supervisor Simidian and Supervisor Lee. I'm happy to be here this afternoon. I'm Christine Tomkala, the CEO of Santa Clara Family Health Plan. And Tyler Haskell will be sharing slides with you today. So moving on to the next slide. As you likely know, 24 years ago, the Santa Clara County Board of Supervisors created us, and we are a public agency dedicated to improving the health and well-being of the residents of our county in partnership with our providers and community organizations. And as you may recall, we are a 2-plan model county, and we are the local not-for-profit alternative to the for-profit Anthem Blue Cross, who is the other Medi-Cal plan in the community. Moving on to the next slide. We have recently refreshed our organizational mission and values, and thought that we should also have a publicly stated vision statement, which we have not had in the past. And so these are sort of hot off the press, and we wanted you to be among the first with whom we share them. In addition, we have the values. We had some values before, but we decided to streamline them and select the key values with input from our staff that we believe truly represent who we are. And so this is the list that we have come up with. Alongside our work to update our mission, vision, and values, our governing board also recently approved a new strategic plan for the next 3 years. And so we wanted to share the 3 key goals that we have that we'll be working on over the next 3 years. The first is community health leadership, secondly, quality, access, and equity, and organizational excellence. And I want to thank those of you who provided us assistance in developing these by providing input, and we are very much in appreciation of that. So thank you. In terms of our programs and membership, we currently have 269,000 total members. They are in 2 lines of business, the largest of which is Medi-Cal, and we have approximately 279,000 members, and we have another 10,000 members in our Cal MediConnect product line. And that is for those of our Medi-Cal members who also have Medicare and would like to have us provide their Medicare coverage. So it's a combined and integrated coverage program. Over the past year, we have had a significant increase in our enrollment. It's gone up approximately 15%, and largely that's a result of the moratorium that was placed on eligibility redeterminations. While we appreciate the 36,000 member increase over the last year, we recognize that when the public health emergency ends, many of these individuals will lose their coverage upon reinstatement of the redetermination process, and our membership will drop because they may now be employed, their income may be too high and so forth. In terms of the COVID-19 impact on our membership, you can see here a number of statistics, and we can move on to a couple slides as well that give us a little more detail. I know we heard the good update from our public health department a little bit earlier. This is an example of how we are performing with our members, getting them vaccinated compared to the county. And so we keep an eye on this to see how much we're trailing and how much of a bigger challenge our members face in getting their vaccines. As we move on to the next slide, we break it down by race and ethnicity. And as you can see, the orange line across the middle is the average for our members. And the three groups that are performing under average primarily are the Hispanic, Black or African ancestry, and American Indian populations. And of those three, the Hispanic population actually makes up 40% of our membership. So that one is of a great concern to us. I will say that among other activities, we have been doing outreach calls to our members who have underlying conditions to provide them assistance with scheduling appointments and transportation. And in getting feedback on those that decline that assistance, the largest reason is concerns about efficacy and safety, with 36% of the members we've reached through those calls expressing those concerns. I will also note that the Hispanic population, their third most significant reason for declining was that they were busy. And so I think the discussion about moving to evening and weekend appointments or availability of clinics is a good thing. Moving on to other community support that we provided during COVID. We started out offering monetary support to community clinics, to the East Side Access Community Wireless Project. We did a number of activities related to providing supplies and/or food. And we have now moved on to participate in the vaccine initiatives. And so I'm very happy that we're working in collaboration with the County of Santa Clara Emergency Operations Center. And we're holding vaccine clinics at our Blanca Alvarado Community Resource Center, which we'll talk about a little bit more later. We're looking forward to hopefully moving some of those clinics to those off business hours. This slide shares some quality comparisons. And I will start out by saying, 2020 was a very unusual year due to shelter in place for measuring quality. So, there was an interruption in service. Telehealth was offered, but some services are just, required to be performed in person. So we are still working on collecting the data for that year. The data you see here is for calendar year 2019, which is the last year for which we have some comparative results on our quality performance. And you can see we're the orange bar sort of toward the left. And this is a comparison to how we're performing compared to all the other plans that provide Medi-Cal in the state. And so for several years, we've put quality improvement at the top of our priority list, and we're pleased to report it's paying off, and we're moving further to the left. In terms of some of our strategies, we have strategies both with providers and members, and primarily we have a pay-for-performance program that provides financial incentives to our providers for their focus on some key low-performing metrics. We also try to work collaboratively with them. We provide quarterly report cards and monthly gaps in care reports, and work with them on trying to have some initiatives to close some of the gaps. Sometimes maybe they're performing the services and we just don't have the data, and in other cases, maybe we need to encourage them to provide some additional services. We also have some initiatives with our members, both in education as well as some financial incentives like gift cards if they receive certain services. And we do provide some outreach and appointment assistance to help ensure that they get the care that they need. And then that brings us to CalAIM, which is a very big issue in the healthcare world these days. So after a state-imposed pause due to COVID, CalAIM is back, and we're working on our long to-do list to prepare for CalAIM. CalAIM is the name for a large set of Medi-Cal reform proposals that were developed by the Department of Healthcare Services in late 2019. And among those proposals are the enhanced care management known as ECM and in lieu of services, ILOS, and we'll discuss those a little bit more in a moment. There are also some new populations that will become mandatorily enrolled in managed care. They are the remaining non-dual enrollees. They are not particularly large populations, but it will pretty much get most everyone in managed care except for foster kids and the limited scope folks, which to a large extent are the undocumented population over age 26. The third thing is ending the demonstration project known as CalMediConnect and moving to a dual special needs plan product, otherwise known as a DSNP, statewide. So while we already are doing a CalMediConnect, there's a lot that's different on the back end. Even though the benefits are largely the same and our members can transition over, there's a lot of work on the back end, a lot of legwork to launch that. So that's what we're starting to work on. And the DSNP would be effective starting in 2023. There are also regional rates proposed under CalAIM, and so while Medi-Cal plans get paid on a capitated basis, the calculation for those capitation rates will now be on a regional basis instead of a county-specific basis. And then lastly, I would like to point out that we are also required to become accredited by the National Committee for Quality Assurance. We are already accredited for our CalMediConnect line of business, but we are working on getting that designation for our Medi-Cal line of business as well. So these are some of the more significant reforms affecting Medi-Cal managed care plans and members, but this is a short list. It is a longer list if we looked at everything. And then this slide just shares a timeline with you spanning 7 years. You can see where different things become effective. And you can also see it's pretty much kind of front loaded there in 21 and 22 and 23. And then some of the new things are tapering off. As we talk a little bit more about the enhanced care management and in lieu of services, note that the state is transitioning from funding the whole person care pilot to rather incorporating some of the promising components of whole person care into Medi-Cal managed care. So, we are looking for a strong partnership with the county in order to continue successful whole person care programs that the Board of Supervisors and the health and hospital system have built. And you'll note that some of the care management elements of these programs will continue under the new ECM benefit. ECM is intensive case management, and that is for the highest risk and most complex of our members. And it basically includes the populations that you see noted there. Then other of the programs will address social determinants of health under what is known as in lieu of services. Now, these are not actually Medi-Cal benefits in the traditional sense, but rather lower cost alternatives to traditional benefits that the state will allow us to provide in lieu of the traditional benefit. And those could be things such as hospitalization or institutional placement. And in this case, under in lieu of services, we can provide some services to help avoid those things. You can also see some of the examples of the DHCS approved ILOS here on this slide. This is just 7, but the 7 probably key ones, but there are 14 potential things that could be included under ILOS. And then it's up to the plan to determine which of those they will be providing. And then the next slide here shows that we do have our new Blanca Alvarado Community Resource Center on the east side. It's located where the old hometown buffet used to be at North Capitol and McKee Avenue. And the Community Health Partnership is leasing some space from us for their offices. although we received occupancy last November, and that was actually delayed because of COVID, we still have not been able to open our doors, swing the doors open to the full public presence, but we are determining a timeline for a phased opening. And as you noted, we are already hosting some COVID vaccine clinics and happy to do that. We also will be starting to provide health coverage application assistance by July. And beyond that, we are engaging stakeholders to help us determine what the best program planning is for our community resource center. And there are some, I think, photos on the next page to share with you. And we're in the process of getting our signage up and look forward to being able to welcome even more members and members of the community to the center. So that is my brief update, but I'm happy to entertain questions.
Thank you very much. Let me turn to Supervisor Otto Lee, see if he's got comments or questions.
Yes, thank you so much. Do want to check in with you regarding the vaccination rates for the members, especially of the ethnic minority groups that we have identified below the average. What specific things you are planning to do or adopt? One and two is we did talk about the issue of some of the homebound seniors who have not been able to get their vaccine. So I'm wondering, among those of your members of your plan, how you plan on reaching to them? Do you plan on providing some type of service to work with getting the vaccinators to actually visit people's homes directly?
And Ms. Tomkala, excuse the interruption, I have to step away for just a moment, so I'm going to leave you in the very capable hands of Supervisor Lee. I will be back shortly. Thank you.
Thank you, Supervisor Smidian. And I am wondering if Dr. Lori can join us on the call. I think she is listening in and maybe can come on screen. We certainly are doing outreach calls to our most medically vulnerable members and trying to make arrangements for them. In terms of the in-home visits, I don't know that we have a particular approach to that yet. And Dr. Lori, I don't know if you can join us.
Hi, this is Lori Nakahira. Thank you for having me, Dr. Supervisor Lee. So we are doing multiple efforts actually to reach out to these members, and we have been doing calls. I'm sorry, I have a lot of background noise here, so I apologize for that. So we have done over close to 10,000 calls out to our highly vulnerable members of greater than 65 years of age. We've also sent flyers out to our members and also during robocalls. We are focusing on the calls to our high risk because we know that over the age of 65, because we're realizing the challenges of technology of trying to schedule. So what we're doing is calling them and seeing if they need assistance for scheduling. And we've actually been working with public health, getting the back lines to help have open appointments for them. And then also we're working with them to see those members who are declining the immunization, why they're declining. And like Christine Tonkolo actually said about the reasons that, there is some hesitancy of just waiting, talking to their primary care physician, and some of the times of when the vaccines are available. To address some of the members who are actually we consider homebound or need in-home vaccines, we are working with public health. And as public health had mentioned earlier, that they have the fire department at this time going out to the homes. We're working on a list to provide. We're also working with our CBAS providers in the community to get a list of those members who have not been vaccinated and assisting them with getting transportation if they are able to leave the home. And so that's what we're doing at this time. Did that answer your question?
No, I think you have, and I just was checking to see. I know offering transportation, of course, is good, but for those who are truly homebound, we might have to actually provide service to do the visit, which of course is very, very high level of service that we're providing. But I think there will be needs of some of those in order to get to the higher percentages. And as far as the issue of the vaccine hesitancy, I've asked those same questions earlier with our own Dr. Fenstersheib and Dr. Cody on the efforts that we're putting in to try to demystify these fake news or inaccurate information, let's say, in the community. And I think it'll be important to be able to get that information out there for people and probably in language as well. So I hope that you will be able to work with the county to get this information out to your members so as to ensure that they understand that this is really safe. So I want to, from the county's point of view, I just want to make sure we are providing that information, to help you to get to your members to work on these.
Absolutely. And for those members who declined the immunization, and I just wanted a little bit more time to see about the side effects and some of the adverse effects that are happening with the vaccine, we have a plan to call them back and actually follow up with actually scheduling them, and at the same time also getting them transportation if they need it. And if they need to speak to their provider, trying to get them appointments with their provider too. So we're trying to do this on multiple levels and work in collaboration with public health.
Great. Perfect. Thank you so much, Dr. Lori.
You're welcome.
And Supervisor Lee, if I may just add, we are also trying to work collaboratively with the Public Health Department through the Stakeholder Committee, and Mike Gonzalez, who is our CRC manager, is co-chairing one of the subgroups and is working actively on trying to identify some of that messaging and things that we can hold hands and work together on to try to get our members and the residents of the community vaccinated.
Great, thank you. And then one last question about this CalAIM program that you have laid out with the 7-year plan. It's a very important long-term plan, and thanks for laying that out for us. It actually mentions something about some of the very high-need individuals that you'll be serving, that are those who have special needs, that has many multiple touches, multiple needs in the future, high needs with the incarceration system, and I just want to mention that we have been talking about a separate issue of the assisted outpatient treatment, and actually this committee moved to the main board in May to discuss the issue of something called the Law's Law issue, which I think there might be some overlap of individuals that might be being served. So I just want to make sure the program that you're working with is in conjunction and will be in coordination so that we're working together to serve some of these very vulnerable individuals in our community.
Absolutely. And, we understand that there's a lot that we need to do to work with the county on the whole person care population that you're currently serving, as well as the health homes population that we're serving, and to try to crosswalk all of the programs and try to figure out how it all knits together. So, we want it to be harmonized, and so we're happy to work collaboratively on that.
Great. Thank you, Chair Simonian, and that's all the questions I have.
Thank you, Ms. Tomkala. I have two very quick questions that are frankly peripheral. The core communication was very clear, very helpful. Thank you. And one slightly sideways comment, I guess. Only the healthcare community could come up with an acronym like DSNP. That was my first observation to no real purpose. I'll let it go at that. I did have just a quick question, and if it's not something you are able to comment on, I'm going to follow up on it with our county counsel, Mr. Press, who's on the call anyway. But on slide 12, I noticed that you talked about member education and incentives, and including gift cards. And I'm just curious about the gift cards. I always wonder about the legality and the medical ethics around providing incentives, quote unquote, in connection with healthcare. I know you and your team are sensitive to that. Could you share a little bit more about under what circumstances they're used and whether or not you find them helpful, and in what amount? And I'm wanting to give the issue some thought in another context, and so I'm using you as my free consultant today, Ms. Tomkala. That's what's going on.
Certainly, and I'm going to start off, and then Dr. Lori may want to chime in because she may have more of the specifics. One of the examples that I think is good to use is not really a gift card, but it is a financial incentive. For example, some of the pregnant moms that we have among our membership, if they go through some prenatal classes, they can earn a car seat for their child or a co-sleeper. So again, if they get the prenatal classes, then they can get one of those incentive items. The gift cards tend to go for example, and actually this is not gift card, I think it's an entry into a drawing. Some of our adolescents who are very resistant to going to see their primary care physician, if they do, I think their name gets put in a drawing and we have something that they could potentially win. And I think gift cards are used for other things like well child visits. And Dr. Lori, can you be more specific for Supervisor Smidian, please?
Yes, this is Lori Nakahira again. So what we do is we do come up with a program, the incentives for some of our HEDIS members, which are well child visits, and some of them are adult visits. And we come up with a plan of who is at the highest risk and not getting their well child visits or cervical cancer screenings or breast cancer screenings and such like that. And so after we come up with a plan and we pass it through our board and our executive team, we actually have to get approval by the Department of Healthcare Services. And these incentives are for all those members within that age group. So it's not necessarily that we can post, and we do post these, and we do kind of encourage the children and the adults to get their well child visits and the services to keep them healthier. So this is offered to this population of those who are at higher risk and not fulfilling at least what we call the 50th percentile. Did that answer your question?
It did, and what I'm going to do is say thank you to you both and ask Mr. Press if we could get an off-agenda memo on the, I'll call it both the opportunities and the limitations of using incentives for healthy behaviors. Does that give you enough to work on, Mr. Press?
Absolutely, thank you.
Thank you. No need to play that out. And now, Mr. McCullough, as I mentioned, slightly peripheral perhaps, but important, I think. And I'm just going to flat out tell you, I'm hoping to put you on the spot a little bit here since I have you in a public venue, and say I have recently expressed concern at the county with the fact that uniquely my district, which, as you know, is somewhat more prosperous than the average or median for the county, has a appreciably lower rate of take-up for CalFresh, formerly known as food stamps, sometimes referred to as SNAP, has a appreciably lower rate of take-up among individuals who have been identified as recipients of public assistance of some sort. So I'm not talking about the general population. I'm saying that even if we look at the population our county has identified as being public assistance recipients, excuse me, in some way, shape, or form, the take-up rate is probably 35 to 40% lower in District 5 than it is in any of the other districts. And, you know, by which I mean, I think we just got a report today, 18-19% of the folks on public assistance as opposed to 25, 26, 27%. And by my estimation, given the number of folks in my district on public assistance, that means that probably 3,000 folks who could be the beneficiaries of CalFresh SNAP program are not accessing the program for one reason or another. So what I'd like to do is ask if, as we attempt to address that under participation, we might work with you, since I suspect that many of your patients and clients are in that category. And as I say, it's an odd one to figure, because the other 4 districts are certainly all very different from one another, and yet their numbers are almost identical in terms of the percentage of take up from district to district to district to district until you hit mine. So can I follow up with you on that after today's meeting?
Absolutely. We'd be delighted to work with you and see if we could collaborate, because, you know, it's also good nutrition, right? So that helps with healthcare. So it's related. And it's the demographic you're looking for, and we're happy to work with you on it.
All right. Thank you for that. And we'll follow up with you and your team. Supervisor Otto Lee, any last questions or comments before we turn to the public, if there are members of the public who would like to speak?
I have no more questions. Thank you.
All right. Then let me turn to the clerk and say, do we have any members of the public who would like to speak on this item, which is item number 9?
We have no speakers on this item, Mr. Chair.
All right, then we'll say thank you to the team from the Family Health Plan, and we will ask if we can get a motion to receive the report from Supervisor Otto Lee.
Yes, so moved to receive the report.
All right, thank you very much. And we'll call the roll just as a matter of process.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you.
Thank you. Thank you. Excuse me. Motion is approved, and we will move on now to item number 10. Thank you again, Ms. Tamkala and team.
Thank you so much.
Thank you. And on item number 10, I think I would ordinarily turn to Mr. Lorenz, but I know he is away this week. Are we turning to Dr. Cho in lieu of Dr. Lorenz?
Yes, sir. Good afternoon, Chair Simidian and Supervisor Lee. Thank you for inviting us today. My name is Nam Cho, and I proudly serve as the Medical Director of the Alvarado Cancer Center at VMC. I'm here today with representatives from two of our valued community partners, Cancer CarePoint and the Pink Ribbon Group. Don Hogue is the Executive Director of Cancer CarePoint. And from the Pink Ribbon Girls, we have President and CEO Heather Salazar and her colleague Julie Arnheim. We at the Cancer Center have a long established and excellent working relationship with Cancer CarePoint, and we are glad to have embarked on a new partnership with the Pink Ribbon Girls. Both groups have been working closely with our Cancer Center staff to identify oncology patients and reach out to them to provide much needed support services, including food, transportation, and psychosocial support. We are happy to answer any of your questions about the report.
Thank you. Let me first welcome you all to today's meeting and thank you for the work you do. Supervisor Lee, I'm going to offer a couple of preliminary comments and then I'll turn to you as well. But what I wanted to do in addition to saying thanks was to indicate that I wanted to follow up on these two organizations and this set of programs and services because it was primarily driven by an inventory item I proposed last budget cycle. And what I would say from looking at the report is that I think we were wise to suggest initially a 2.5-year cycle with a 6-month delay because it does take time in our county system to ramp up programs of this sort. That being said, it does look to me like we have still not ramped up these programs as quickly and as robustly as we would like. Is that a fair summary, Dr. Cho?
Yes, it is. I agree.
Thanks. And I was struck by even the brief narrative in the report as to how really tremendously valuable the services are for the folks that we're able to help. But I think we got to get the numbers up. I know some of that's just the startup delay. Some of that I gather is a function of revising the intake form, if I understood the report correctly, and if that's going to help us in the long run, I'm glad it got done. And some of it is, of course, inevitably COVID. Let me ask Ms. Salazar and Ms. Arnheim from Pink Ribbon Group what their thoughts are about how we can up the numbers that they serve as expeditiously as possible. And I'll just toss out a couple of thoughts, which is, should we be talking about serving a wider range of clients in the VMC system, meaning folks who have other kinds of cancers than are currently addressed? And or should we be talking about going wider with other healthcare institutions and hospitals in Santa Clara County outside our Valley Medical Center system? And of course, we're concerned about making sure that these services get to people who need them wherever they are residing and or wherever they're getting their health care. So Ms. Salzar, Ms. Arnheim, how would you like to begin the conversation? And one more thing, and I should have said this at the outset, forgive me as I look at your faces. For some of you, this is the first time in the committee. So here's what I want to say. You're doing extraordinary work, but we need to do more and we need to do better. And we're going to have that conversation right here, live and in public. And it's a positive conversation. It's about how we can make more good things happen. If there are places where we haven't done as well as we could have or should have, we should just say so and figure out how to do better. So don't anyone feel like it's anything other than a problem-solving exercise among people who have good values and are doing good work. Now, hopefully, Ms. Salazar, that'll make you feel comfortable leaning in and telling us what you think we ought to be doing next.
Thank you so much for having me. Can you all hear me?
Live.
Okay, great. Thanks so much for having me, Supervisor Simidian, and we appreciate your work. I can tell you we've been working great with Dr. Cho and Barbara French from the Alvarado Cancer Center. We have served 100% of the people who have been referred to us, which has never happened at other big, large hospitals that we've gone to, such as like WashU, Ohio State, when we went through their social determinants of health. And one thing that we've realized is the socioeconomic difference, obviously, from the people who really need it. We have used the clients of Valley Med in our last 3 updates from a national level. The first one being the lady who only ate bread. We tried to defer our meals because she didn't have a refrigerator. So our team sent her a refrigerator so that now she can get our meals. It's kind of been heartbreaking. But what I can say, we've had 18 new referrals in the last 2 weeks. And Dr. Cho, Barbara French, and the social workers have referred. We've now gotten the form down to a 1-page. We're also doing some even verbal referrals and then following up with the form later so that your patients can get their rides more effectively and faster. And the social workers are now starting to come back to work in person at the facility as well. So that's kind of helping streamline some of the paperwork. We feel really honored to be serving these patients. It has definitely been the patients of highest need that we've been. So I would like to say is I agree with you. Meaning if we don't get the referrals up in the next couple months, I think that we do need to see, okay, should we try to work with more cancer patients? What do we do to get the referrals up? But the feedback and the need that we're getting from the social workers at Valley Med and the physicians has been just amazing. So, I mean, Dr. Cho, do you think that we're referring and getting the patients completed with their services faster? And what feedback do you have for us?
The feedback I'm getting from our oncology nurse navigators and the social workers is that working with Pink Ribbon Group has been excellent experience. I know there was a initial slowdown in the referrals because that intake form was so onerous to our workflow, but because that's now been settled, I think we should be able to increase the numbers of patients that we do refer to you. There is a lot of need, as you said. I do think that the numbers that are projected or proposed for the Pink Ribbon Girls is really ambitious, given the actual volume of new cancer diagnoses at our hospital and also even in the county. So I do think that if we want to meet those targets, really expanding the eligibility to, if you're however, I think we might want to discuss further how best to expand the eligibility, because there are many more patients than the ones that have been sent to you who would benefit. But I think we want to make sure that they are meeting the criteria that you set out at the beginning.
Okay.
Great. Ms. Salazar, anyone else from Pink Ribbon Group that you think would be right to pull into this conversation, or do you feel like you've got what you need and we've got what we need to carry this conversation on?
Julie, did you want to add anything?
Yes, I would just say in our report, we also talked about the impact on Santa Clara County, and we are getting more and more referrals from our outreach, from the need, from people delaying going and getting their mammograms and their diagnoses. we're seeing from Stanford, from Kaiser, from Sutter Health.
Right.
So it is definitely, we will have a greater impact of numbers in Santa Clara County. And then it's just a matter of how many patients we get from Santa Clara Valley Med hospitals.
All right. Dr. Cho, is George Harrell the right person to pull into this conversation from the BMC standpoint if I wanted to talk about contract provisions?
I do believe so, yes. We can check in with Paul when he returns, but I think, but George has been my contact for this.
And I don't know if Mr. Harrell's on the call today or not.
He's been great for us to work with as well.
All right. Here's what I'd like to suggest, and and Cancer Care Point, please not to worry. I see Don waiting in the wings. We'll be right to you. What I want to suggest is that we, after we finish up the conversation today, we ask that we continue the item until our June meeting, and ask you to use the intervening time, the next couple of months, to address how we might proceed and boosting the numbers, either, as I said, by referring a broader range of patients, Dr. Cho. That's I think you know what I mean by that. That's my shorthand for other kinds of cancers, and or expanding the effort for Pink Ribbon Group and Cancer Care Point in a moment to other institutions where you are already at work, as I understand it, and or extending the time frame of the contract so that you are doing, you may be assisting fewer folks per year than originally expected, or anticipated, but doing it over a longer period of time. So we take the same number of services, but instead of doing it over 2.5 years, you do it over 3.5 years, as an example. Some combination of those, and my office and I will be happy to invite ourselves to your party and work with you on that in the next couple of months to make sure that we figure out how to do that. Does that sound like it works for the folks at Pink Ribbon Group?
Absolutely.
Yes, that's great. Thank you.
Okay, thank you for that. And Dr. Cho, does that make sense from a standpoint of our county organization?
Definitely. I would add that we have oncology services at O'Connor Hospital, and a new physician who has started to, an employed physician who's working there and helping with that, and as well as expanding down to St. Louis and the DePaul clinic. So I think we have opportunities there, even within our enterprise, to expand those numbers.
Yeah, and as I said, in addition to expanding within the enterprise, you know, if there are patients out there who need the help, want to make sure they get the help they need, sort of regardless. And Dr. Cho, can I lay it on you that we've volunteered Mr. Harrell to get into the conversation as well? I'll just let him know that you said that was okay.
Definitely.
Thank you. All right, then let's go to Cancer Care Point. And I see Don Hogan there. All right, can you hear loud and clear?
I can. Thank you, Supervisor Simidian.
Sure, thank you. And similar questions about sort of what you think has limited the numbers of folks you're able to serve during this first 3 months, the first quarter, plus now that we're into the end of April. And again, feel free to just sort of tell it like it is, or call them as you see them, so we can figure this out and do even more for more folks.
Absolutely. Thank you, Supervisor Simidian, for your support, and thank you, Supervisor Lee, as well. It is very similar to what the Pink Ribbon Girls were saying, which is during COVID and certainly for, you know, really through the end of the year, it was all hands on deck from the medical side, and we didn't have an opportunity to interact with patients. And I know the medical interaction was limited, as well as talking with Dr. Cho and Barbara French. And so that just decreased the opportunity. Now that things are starting to open up, more availability to actually even make connections within the medical system, that has helped. So the individuals we served were part of kind of our ongoing relationship with VMC. nothing out of the ordinary that had come out as a result of the contract. But now we've had additional conversations with Dr. Cho and Barbara French and the oncology navigators and social workers. And we have some great ideas that Dr. Cho and Barbara mentioned of additional services we can provide and making it really easy for the patients to get those services. Also, Mr. Harrell connected us to St. Louis. So we're going to have those conversations with St. Louis about what we can do for clients over there. So it started very slowly, as we said, but I think in certainly in the second quarter and definitely in the latter half of the year, I would expect it to us to easily be able to get those numbers back up.
All right. Well, I'm going to ask that we include you in the conversation that we revisit in June, and again, as to sort of at least 3 different ways we might approach this. We'll pull both Dr. Cho, but also Mr. Harrell, as you heard, into the conversation. Again, thank you for the work you're doing. As I said, it's rare that you can have just a couple of snippets that communicate so fulsomely how much value there is in the kind of help you give. My office and I will reach out to you in the interim. We'll try and facilitate those conversations, and just know we'll be nudging you in the most supportive of ways as we go forward.
We love it.
Okay. All
Thank
right,
you very much, Supervisor Simitian.
Thank you. Let me see if Dr. Cho has anything else before I return to Supervisor Lee, and then I want to make sure we go to members of the public who may be standing by.
I would only add that we make sure to invite Barbara French, our nurse manager for the cancer services, to that meeting. Thank you very much.
Sure. Let's make sure that we do that, and please pass our thanks along there as well, Doctor. Supervisor Lee, thank you for letting me tee that one up as much as I did. Do you have comments or questions you'd like to offer at this time?
Yes, I just want to thank those who were there for the Pink Ribbon Group and also the Cancer Care Point for the amazing work you are doing for our community. It's absolutely crucial. And as you mentioned, during the COVID, it certainly makes it harder for people to get the service, or for the matter, getting the mammogram. As we know, any delayed screening could potentially be deadly, because breast cancer especially is one which is extremely aggressive. By not detecting it in a few months could make a huge difference for potential cure. So I just want to make sure that as our county, whatever we could do to help, whether it's outreach or information awareness or reminders to people who've missed appointments, there's a way we could track that to send urgent reminders that, hey guys, you really need to come in to get checked, and it's safe. Now that a lot of people are getting the vaccination now, this is a much safer time frame that people should not be fearful to go to the hospital to get these checkup being done. So I think it would be so important.
Thank you.
Thank you, Supervisor Lee.
Thank you. And I did.
All right.
Thank you.
Let me turn now to the clerk and ask the clerk if we have speakers standing by.
We have no public speakers, Mr. Chair.
All right, then we'll ask that Supervisor Lee, if you're amenable, that you move the recommended action with direction to hear this item again at our June meeting, and ask staff and our contractors, Pink Ribbon Group and Cancer Care Point, to work collaboratively with board offices and county staff to figure out how we can up those numbers and or extend the period of time.
Yeah, so moved. I actually have a minor amendment too. I would like to add, as been mentioned, the Latinas Contract Cancer Group as well. I would certainly want to add them to the dialogue as well, to outreach to the Latinos community, which they have done an amazing job of. So I actually make sure that adds to the motion, and so moved.
Happy to include them because I know they do this work in part in collaboration with Cancer Care Point. So we ought to have all the voices and participants and contributors at the same conversation. All right, then we'll ask the clerk to call the roll. I'll second the motion.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye.
Thank you.
Thank you. That motion passes. And again, thank you to all of you for your good work. Appreciate it. And I know it was a long meeting to wait through, so thank you for that as well. All right. Supervisor Lee, that takes us to item number 11. And let's see what we have here. We start with, I believe, Mr. Santiago, who will give us a verbal report.
Yes, and good afternoon, Mr. Chair Simitian and Supervisor Lee. It's good to see you. I'm glad you're safe. A couple of notes that I wanted to emphasize on the director's report. Obviously, very grateful not only for the partnerships with the cancer prevention and treatment organizations, but then also with Family Health Plan. As you know, we've been given updates on the whole person care on a regular basis. We have the latest update on the whole person care, indicating that we've been collaborating with both managed care plans. And as Christine mentioned, she has been a founding collaborator with us since the very beginning on the whole person care project. And then, of course, as the state moves to broadening the benefit to all the Medi-Cal population, we continue to partner with her to expand that care and services. The other piece I wanted to bring to your attention, especially as we head into the budget discussions, is we've gotten very tremendous support at the legislation, both on the Assembly and the Senate side, for a $300 million request for public hospitals. The California Association of Public Hospital Systems is carrying that for us. Our former supervisor and now state senator Dave Cortese has signed on to the letter. It's gotten tremendous support across the urban areas as well as some of the rural communities. And so just wanted to bring that to your attention, because we may be asking you a favor as the negotiations of the state come to a head, to reach out to your colleagues at the state Senate and Assembly. What this request would help us is to deal with some of the uncertainty that we have around the financing of VMC, O'Connor, and St. Louis that I know that you've been keeping very close eye on, particularly because the American Rescue Plan, as you know, even though it does provide funding, it doesn't necessarily provide additional funding to hospitals. But yet, on our local experience, our public hospital, as you know, has been doing quite a lot in the community for testing, for vaccinations, and other kinds of things. So I think we actually have some very specific experiences here locally, where public VMC in particularly, but also O'Connor and St. Louis, have been doing a lot of community work that would obviously merit reimbursement, whether it be from the federal and definitely support from the state of California. So we'll keep you up to date on that piece and share information to your relative staff as that moves along. That concludes my comments, unless you have any specific questions about the items that I covered on the emerging issues.
Supervisor Lee, unless you have comments or questions, we'll go on to the other subcategories here under item 11. That seems to be okay. We'll say thank you, Mr. Santiago. Report from the public health officer, I believe, has been received, unless there's anything else.
No, that's it. I think Dr. Cody had to leave, so.
All right, then the report from the Chief Executive Officer of Santa Clara Valley Medical Center. I don't know who might be standing in today for Mr. Lorenz, if anyone.
Yours truly. Paul is away. We did give him a break for a week to relax and refresh and come back just as energized as he's been. One of the things that we wanted to cover with you is that, as you know, we've had lower cases in terms of hospitalizations for COVID that allowed us to use our capacity to continuously bring back patients into our facilities. So the report indicates that not only in terms of the utilization, but then also the revenue associated, particularly O'Connor and St. Louis have exceeded budget to this point, but also VMC has caught up to what it was before COVID, although we still have some ways to go to make sure that we cover and take care of all the patients that are in need. The other piece that I wanted to share with you is we also have a very extensive report on quality as part of the attachment. This is kind of a regulatory requirement. We'll give you a comprehensive report. It has a lot of data, a lot of information on a variety of different topics and issues. Jill, our Chief Nursing Officer, is available, as well as Carolyn Brown, if you have any specific questions around quality. That concludes our VMC report, unless there's any questions.
And again, I'm going to go on to the next item unless I see my colleague Supervisor Lee raising his hand, which I do not. So we'll say, do we have any additional report from behavioral health today?
Good afternoon, Chair Simidian and Supervisor Lee. Just a couple of updates in our monthly report from behavioral health. First, we wanted to welcome our newest executive member to our team. Zelia Faria-Costa is our newest executive representing our Children, Youth, and Family Division. We're really excited to have Zelia on board. And then the other areas are just simply progress updates. We're moving forward with our community mobile response, still awaiting a finalization on the date to be able to take our plan to the state, but tentatively looking at May 27th to be able to advance that with the Mental Health Services Act OAC. We are continuing to prepare for the May 25th board meeting with respect to assisted outpatient treatment. And then finally, we provided a brief update on our Mental Health Student Services Act, a Wellness Center grant update, which is a partnership with Santa Clara County Office of Education. And we're looking forward to being able to develop those wellness centers with the partnership of school districts in the county. So that concludes my update.
All right. Let me ask my colleague, Supervisor Lee, if there are any questions or comments on that portion of the presentation. There are not. All right, then we will say thank you and welcome to your new colleague, and look forward to working with her. And that takes us then to E, which is the verbal report from the CEO of the Valley Health Plan. And I'm pretty sure I saw it. There you are. Speak right up, Ms. I think we still have you muted somehow, or you have you muted. Still muted. I'm sorry. Let's try it again.
Did that work?
There you go.
Okay, thank you. So sorry. Thank you, Supervisor Simidian and Supervisor Lee. You have our report. I'll give you a couple of other updates. We are also calling our members and helping to schedule vaccine appointments for them. These will be the most vulnerable members that we have, and we are doing that work as well. We've also really focusing on our HEDIS scores, and we are developing a value-based payment process to help get those HEDIS scores up and really improve the care and the quality that our members are receiving. And this again is in support of our NCQA accreditation, which we are also pursuing, and will be a multi-year effort. It is a lift because it's a very robust accreditation. And those are my updates, unless you have any questions.
I'm good for the moment. Supervisor Lee, you okay? Then we'll say thank you, Ms. Rosas. You got away clean. Good for you. All right, thank you. And then that takes us to the report on Emergency Medical Services Agency. Did I see Ms. Lowther? I think I did.
Yes, yes, sir, you did. Good afternoon, Supervisor Simidian, Supervisor Lee, Jackie Lowther with EMS. And you have our report before you. Compliance is good from both our ambulance and first responders. Responses were a little off in February, March. Responses picked up a little bit. So we're getting a little bit back on track, as well as April so far. A little bit inconsistent from day to day, but overall things are starting to look a little bit like they did in 2019. We also gave you an update on trauma, just to change things up from month to month to give you a full overview of the entire agency and everything that we do. So if you have any questions myself and Dr. Miller are here to answer any of those for you.
All right. Thank you. Again, I think I'm good to go. Let me just look. Supervisor Lee, you're okay? Thank you, Ms. Lowther. Thank you, Dr. Miller. Appreciate it. That takes us to item G, which I believe will be Dr. Day for custody health. Yes.
Yes, good afternoon, Supervisor Simitian and Supervisor Lee. Custody Health Services continues with a very aggressive by next down daily testing and weekly testing with our staff, as well as asymptomatic surveillance testing with our patients. We continue to have low positivity rates on both the patients as far as the youth and the adults. And for the month of March, we completed 11,343 tests on just our staff alone. And these are the by next now 15-minute tests that they take before they enter into the perimeter. And right now we're continuing with the vaccinations of patients, and then we have a very aggressive vaccination of patients. We continue to have rolling clinics so that we're catching new patients coming in, so that we're always offering those vaccinations to patients as they're coming in and as they're leaving. And that's my report. If you have any questions.
Thank you very much. Supervisor Lee, any questions? No?
It's a couple. One is regarding the daily testing. So we've started this mandatory daily testing for all staff and other facilities now. How has that been received by the staff, and what's your takeaway so far?
So far, what we have done, Supervisor Lee, is that we have reduced the testing for those staff who can actually present and voluntarily present their vaccination cards. And so if they present their vaccination card, then they only need to test once a week. And we were hoping that that would incentivize other folks to present their vaccination cards. But if you have not presented your vaccination card, then you are still required to test daily.
Got it. And how is that encouragement working? Do you see more and more people? Because last I saw, I think 55% still wasn't interested or don't know, right? So are we looking at those numbers dropping anytime soon?
Right, we're still looking at the numbers. We so far on the custody health services side of the house, we have about 278 staff out of the 403 that have completed, that are presented their vaccination cards to us. And so they're testing once a week. We're still providing education to our staff. We're still, encouraging them to vaccinate. We have twice a week town hall meetings where we have the huddles, and we continue to encourage and give information out. We have done a hesitant surveillance test, I believe, hesitant surveillance survey. And so still trying to encourage folks to, ask any questions. We've had town hall meetings with the Deputy Director of Public Health. And so we're still continuing to encourage that vaccination of our staff.
Right. So looking at some of the listing from the previous Office Senate report came in April, I think the custody health service is actually one of the better ones in terms of numbers. The one that's more concerning is really probation custody bureau, where there's still over 40% the people who has declined for whatever unknown reasons, right? So I'm just trying to find ways to get the word out there to those folks, and want to see what type of additional efforts we're doing to outreach to them.
That's correct. And we'll defer that to the Sheriff's Department.
Okay.
Thank you very much.
Thank you.
And I believe that takes us to Mr. Margolin for the last piece of our reports here under item 11. Mr. Margolin, are you with us?
I'm with you, Supervisor Simitian and Supervisor.
Thank you. What should we know today?
So I have a relatively brief report today, because there has not been a lot of activity in federal health policy over the last month. Most of the focus has been on President Biden's two infrastructure initiatives, the American Jobs Plan unveiled last month, and the American Families Plan that was unveiled this morning, just a few hours ago. On the health policy front, the American Jobs Plan had only one health-related feature, or primarily one. It was a $400 billion commitment to increasing access to home and community-based services for seniors and those with disabilities. That was the major piece there. And then in the American Families Plan that was unveiled this morning, there is one major healthcare component that builds on the ACA achievement contained in the American Rescue Plan. You may recall that in the American Rescue Plan, the $1.9 trillion package signed into law, excuse me, early in the administration, the main issue they addressed was affordability under the ACA by creating a new cap on out-of-pocket costs for policyholders. Thanks to the American Rescue Plan, Covered California estimated that Californians who receive subsidies will have their payments decreased by an average of $119 per month, nearly over $1,400 per year. These increased subsidies in the American Rescue Plan were only guaranteed, however, for 2 years as a way of keeping the price low in that original package. What the American Families Plan, today's unveiled package, does is to make those subsidies permanent. So that's going to continue on an indefinite basis in the new package put out today by President Biden. President Biden has made it clear, however, that both proposals are a starting point for negotiation with the Congress. While most of the media attention has been on whether or not there can be bipartisan support for these proposals, Republicans and Democrats coming together, there's actually an even more significant negotiation to be had, especially in healthcare, between Democrats in the Congress and the administration on what should be in these bills. So here are a few of the unresolved issues where Democrats in Congress have one view on health and the Biden administration has another. As I mentioned before, in the American Jobs Plan, there was only this home and community-based services funding. There was no money for healthcare bricks and mortar infrastructure. House Democrats, the Energy and Commerce Committee, under the leadership of Chairman Pallone, put out several weeks ago a bill, though, their own approach to infrastructure, where they put in $40 billion in healthcare investments, including money to recreate the Hill-Burton program, which provides money for construction and modernization of hospitals. They also have money in there for revitalizing and rebuilding clinical laboratory capacity in the country. House Democrats will clearly push for the inclusion of healthcare infrastructure in this package. And then Congressman Pallone, the chair of Energy and Commerce, put out a statement this morning, actually, complimenting the president for his American Families Act, but pointedly noting that drug pricing reform was not in the package. You'll recall that over the last 2 years, the Congress has been debating how to bring down the cost of drugs. Chairman Pallone made it clear that this will be one of his top priorities going forward in terms of getting a provision along the lines of what he's advocated for in the past into this package. The issue here specifically is whether the federal government, specifically Health and Human Services, will have the power to negotiate with drug manufacturers for lower prices, something that's been resisted in the past by Republicans and by some Democrats. That's what the House Energy and Commerce Democrats want. Senate Democrats have their own concerns about this package. There was a letter sent out a couple of days ago by 17 Senate Democrats, including our own new senator, Alex Padilla, who sent to the president, and it said essentially that they want the American Families Plan to include a reduction in the Medicare eligibility age. They want to also expand Medicare benefits to include hearing, dental, and vision. And they also echoed the House concern, Chairman Pallone's concern, that the authority to negotiate lower drug prices should be in this plan. So the negotiating table has been set for these infrastructure bills. And even though the president starts off limiting his proposal to this permanent extension of the ACA subsidy provisions, it's very important policy and it's going to have broad-ranging impact. House and Senate Democrats appear determined to try to expand his vision on healthcare, and that's how the negotiations begin. We will keep you advised on these negotiations as they progress. I'm happy to respond to any questions you might have.
Thank you very much, Mr. Margot. One perhaps quick question.
Sure.
I saw the press stories about the push by, I'll call them the Senate 17, to reduce the Medicare age. I did not see any mention, and I looked, to what age? Which is sort of a key question.
Sure. So in the letter,
Do we know if there's a number?
Yeah, what they did is they gave examples. If I have the letter in front of me here, they gave examples, and they talked about how many people would be impacted if we lowered it to 55, if we lowered it to 50. So they didn't come up with a specific number. They said at the age of 60, would expand Medicare coverage to 23 million people. If you lowered it to 60, if you lowered it to 55, you'd include 42 million people. So they just gave a menu of options, 3 different age age targets, and it's all part of a negotiation.
I was just going to say, as a former legislator yourself and someone who watches the federal process, does it strike you that that is designed to avoid putting themselves in a position where they're negotiating against themselves on a number and sort of simply throwing out 3 numbers, all of which would do good things in their view?
Yes, and again, I think getting this done is going to be incredibly difficult, and they're trying, in a sense, the 17 members also represent different philosophies about how fast to go. Some want Medicare for all. Senator Sanders was the lead on this letter. I'm sure he wants the age to be 50 without question. I'm sure other senators who signed the letter are more comfortable with 60. So this may have also been an internal negotiation to get 17 senators to sign the letter. If they put 50 in there, I'm guessing a few wouldn't have signed.
Got it. Thank you. And then I want to go back to the issue of the subsidy increase being initially 2 years, if I understood you correctly, and now the proposal. And do I understand correctly that that's all it is at this point, is a legislative proposal for a permanent extension, or is that somehow achievable without legislative action?
No, it has to be done through legislative action, and it's in President Biden's American Families Plan that he'll talk about tonight.
All right. And I'd be curious to ask you and Mr. Santiago, you or Valley Health Plan or somebody can chime in here if it's helpful and appropriate. We've made efforts repeatedly at the county to try and get as many people to sign up for insurance of one kind or another as we possibly can, whether that's Medi-Cal or whether it's the Valley Health Plan or whether it's through Covered California. And we, have used the increased subsidies as a marketing tool, frankly, to say, hey, if you were resistant before because you thought you couldn't afford it, the increased subsidies may make this more manageable for you. And then my recollection is that as part and parcel of that, we had a series of extended eligibility dates or open enrollment periods. Where are we in all of that? And what I'm trying to figure out is, are we looking at yet another window of opportunity when we should be thinking about reaching out to people to say, hey, there's a good reason to look at Covered California again, even if you passed in previous iterations? Why don't I start with Ms. Rosa, since she's just joined us.
Sure, thank you, Supervisor. So there is a big push on the part of Covered California at the state level to push enrollment. It is open until December 31st. The increased subsidies really can push people into the Silver Plan, which has much lower co-insurance costs. And we've been asked by Covered California at the state level to put together a pretty aggressive marketing plan and really try to get people enrolled as much as possible until the end of the year. So we're putting a lot of effort into that. We have a marketing firm. We're developing the materials. We have been pushing a lot out on social media, both on the vaccinations and on the availability of Covered California. We think it's incredibly important. And we're hoping that as the economy recovers, we'll see an increase in Covered California and probably likely a decrease in Medi-Cal.
And do I understand from you and Mr. Margolin that the reduction, excuse me, the increase in the subsidy at present is the one that was already in place for 2 years. And we're not talking about any change to that. We're talking about whether or not legislation will be enacted that will essentially make it permanent. Is that where we stand at the moment? I'm trying to follow the bouncing ball here.
That is correct. The numbers are not changing.
Okay. And in terms of a legislative timeline, and Ms. Rosas, I'm asking this question particularly because I'm trying to think about the marketing timeline. When will this be a settled issue so that we might be able to, I don't know if this is legislatively something that's likely to happen in a month, 3 months, 6 months, or in the we'll know it when we see it when the time comes category. Mr. Margolin, any ability to predict?
You're talking about this extension that the president's proposing. They're going to attempt to do it over the summer and get it enacted. But again, from the standpoint of marketing, the plan that we currently have in Santa Clara County, marketing the options that are available, the numbers are already out there and fixed. And this is sort of an inside baseball legislative effort, whether it's 2 years or 10 years, certainly affects longevity of the program and the survivability of the program, but it doesn't affect what's being offered to consumers in the next few months.
But it does affect our ability to guarantee to consumers that this will be a reduced cost over the long haul. Does it not?
It does, but I think, well, you're talking about, my assumption is that when you sign up someone for one of these plans, and I should defer to Ms. Rosas for clarity on this point, you're signing them up for a year time period initially. Is that correct?
Yes. So it's for 1 year, and then there is an
these
automatic
subsidies.
enrollment. Right. They can stay in it for, they can just, it'll automatically renew after a year, but it's for a year. So this current subsidies are in effect for the next 2 years. So there's still a great amount of value in it for the members for the next 2 years. And hopefully
I want to be a glass half full guy, not a glass half empty guy. But I think right now I would say, great to be able to say to somebody right now, hey, there's an increase in the subsidy. There's an appreciably lower cost. And Mr. Margolin, I thought it was helpful of you to point out just, how much that adds up to over the course of a year. But I think there may be a marketing hook. I'll leave this to your marketing consultants, Ms. Roses. If Congress acts to make this permanent, I think that's an opportunity to say to the public, look, Congress has just acted to make this lower cost product available on a permanent basis, continuing as far into the future, and all the more enticing than something that people might think of as great, I get it for a little less a year or two. So, all right, enough said on that one. Supervisor Lee, thank you for letting me walk through that one to get my own thinking a little bit clearer. Any comments or questions from you beyond what we've already done?
Yeah, I think you've asked most of my questions. I guess my only question with Mr. Margolin is just clarifying the different legislation that's coming through, since there's so many. So there's the American Rescue Plan. That was 1.9 trillion that we already passed.
Already passed.
You call it the American Jobs Plan. Is that the infrastructure one? Or is that a separate one?
Yes, that is the harder infrastructure plan. By that I mean it's the infrastructure plan that, while not totally traditional, is more along traditional lines. And then the president, I think tonight, is going to try to cast the American Families Plan as still infrastructure related, because he's defining infrastructure more broadly. And there's a reasonable chance, because they'll both be passed through reconciliation, that they'll be merged at some point in the process. But he's starting off with 2 separate packages.
Oh, wow. Okay, good. Yeah, so I just keep hearing this 1.8 trillion infrastructure plan that is on the book. So that's both of these together.
Well, it's going to be
all
more,
right,
but it's a lot of money.
Okay, good. All right, thank you so much. That's all I have.
Thank you. Let me check with the clerk to see if we have any speakers on item number 11.
We have no speakers, Mr. Chair.
Then without objection, I'll ask for a motion to receive the reports under item 11. Supervisor Lee,
Yes, so move.
I'll second, and we'll ask the clerk to call the roll just for the record.
Vice Chairperson Lee,
Aye.
Chairperson Simitian.
Aye, motion carries 2-0. And Supervisor Lee, that means we have covered all the items on today's agenda, having previously acted on consent calendar items 12 through 18. That takes us to our adjournment, which is item 19. And we will adjourn the meeting until the next time we meet in May. And just a reminder to all, I believe that date is in flux or has been set anew. So please double check your calendars. Thank you all for your participation and your help today and the work you do. Take care.